national. Tugushimiye si bashoboye gushikana muri iki kibanza batumire, tugushimiye kubahwa baje gutera iteka iyi Congres Scientifique Dentaire. Reka mwami Imana ubane n'umwe wese muri kino kibanza, reka ubane n'umwe wese mu vyumviro, amaheshanje aze kugenda neza. Iyi minsi ibiri tuzomara hano, mwami tubane nawe, utugirire neza nk'Imana, mu izina ry'uwaducunguye Yesu Kristo dusabye dushima.
Applaudissons pour la prière. Monsieur l'assistant du ministre de la Santé publique, vous prenez place. Madame la déléguée du gouverneur de la province Bujumbura, Monsieur le délégué du bureau de l'OMS Burundi, Madame la présidente de l'association des chirurgiens dentistes du Burundi, Mesdames et Messieurs les représentants des institutions publiques, privées et des partenaires au développement du secteur de la santé, Mesdames et Messieurs les hauts cadres et cadres du ministère de la Santé publique, distingués congressistes, chers professionnels de la santé, chers étudiants, bonjour. Donc, sans tarder, je vais vous présenter le programme. Sans tarder, nous allons suivre un mot d'accueil qui sera prononcé par la déléguée du gouverneur de la province de Bujumbura. Après, nous allons suivre un discours de Madame la présidente de l'association des chirurgiens dentistes du Burundi. Et après, nous allons écouter le discours du délégué du bureau de l'OMS. Et enfin, nous allons suivre l'ouverture officielle de ce congrès scientifique de la médecine dentaire, édition 2026. Sans tarder, nous invitons Madame la déléguée du gouverneur de prononcer son mot d'accueil.
Monsieur le représentant du ministère de la Santé publique, Madame la présidente de l'association des chirurgiens dentistes du Burundi, chers professionnels de la santé, distingués invités, Mesdames, Messieurs, à vos titres, grades et qualités respectifs, bonjour. C'est avec un immense honneur et un réel plaisir pour moi de prendre la parole aujourd'hui au nom du gouverneur de la province de Bujumbura, qui est dignement empêché, pour vous souhaiter la plus chaleureuse des bienvenus dans notre province de Bujumbura, à l'occasion de l'ouverture de ce congrès scientifique dentaire. Accueillir cet événement d'envergure nationale et internationale. Distingués invités, Mesdames et Messieurs, la santé bucco-dentaire est un pilier essentiel du bien-être général. Pourtant, elle reste le parent pauvre des priorités de santé publique. Les maladies bucco-dentaires, classées parmi les maladies non transmissibles, touchent une grande partie de notre population et impactent lourdement sa qualité de vie. C'est pourquoi nous tenons à exprimer notre profonde gratitude au ministère de la Santé publique à travers le programme national de renforcement de notre système de santé. Ce congrès offre une plateforme idéale d'échange, de partage d'expériences et de mise à niveau scientifique pour nos professionnels de la santé. Nous sommes convaincus que les recommandations qui sortiront de vos travaux guideront l'élaboration de stratégies encore plus efficaces pour la prévention et la prise en charge des affections bucco-dentaires dans nos communautés. Chers participants, tout en vous souhaitant des débats riches durant votre séjour parmi nous. C'est sur ces mots d'espoir que, réitérant les souhaits de cordial bienvenue de l'autorité provinciale, je souhaite plein de succès à vos travaux. Je vous remercie de votre aimable attention. Que Dieu vous bénisse.
Good morning, everyone. I hope the translation headers are working for those who are not going to be able to understand English. Good morning, everyone, and welcome to the first International Dental Conference organized by ACDEBO in Burundi. Dear government officials, representative of the Governor of Bujumbura, the representative of the Ministry of Health officials, dear ACDEBO members, dear sponsors, dear institutions, representatives, and dear friends of ACDEBO, leaders, and everyone who have come to support this historic event, welcome. It is an honor to have you with us, and we appreciate your time granted to us. This conference doesn't just serve as a learning experience for us, but also exposure to the advanced modern dental treatment options available. We want dental surgeons to get inspired to specialize in order to be able to provide specialized dental treatment in the country. This will improve the quality dental treatment in the country and will be a great boost to the health system in Burundi. We have invited international dental medicine specialists from different countries to share their knowledge with us. Let me express my sincere appreciation to their voluntary spirit willing to help the dentistry or dental medicine sector in Burundi. Thank you once more. We extend our gratitude to the international dental supplier and manufacturer Shofu and the different pharmacies here long-term for us to be able to experience your products and give the right treatment to our people. To our dear leaders in the government, especially in the health department, we're happy that you have shown interest in support for the oral health department for the past few years. We as ACDEBO have looked forward to close collaboration with you in order to improve the oral health situation in the country. We thank you for supporting ACDEBO and other dental institutions. We want you to remain with us and see how important oral health dental technology has advanced, so that you continue to support the dentists in Burundi to achieve and reach this level of providing treatment for Burundians. We have special request suggestions to our health minister and representatives that are here and those that lead us. We want to be granted all our rights as doctors in the medical councils, but of course it starts with our communications and collaborations. This affects every development of dentists, their specialization options, and we depend on the facilitation that our Ministry of Health provide. So we are taking this opportunity to speak with you and interact with you during this dental conference as a way of communication and passing a message that we are very willing to work with you so that we can improve this health sector together. We know you will listen and work with us to have these positive changes. We welcome you once more to this conference. May we learn and have a great experience together. Thank you.
Merci, merci à vous aussi, Madame la Présidente de la CTBU. Je vous invite d'applaudir encore une fois son discours. J'invite le délégué de l'OMS au Burundi de nous présenter aussi son discours.
Au nom de l'Organisation mondiale de la santé au Burundi, permettez-moi de vous remercier et féliciter le ministère de la Santé publique et l'Association des chirurgiens dentistes du Burundi qui ont travaillé main dans la main et d'arrache-pied jusqu'à l'aboutissement de ce congrès scientifique. Excellences, Monsieur le délégué du ministère de la Santé publique, distingués invités, Mesdames et Messieurs, les maladies bucco-dentaires portant en grande partie sont à l'origine d'importantes charges de la santé dans de nombreux pays. On estime à près de 3,7 milliards de personnes touchées par des affections bucco-dentaires. Et les caries non traitées constituent l'infection la plus courante. Excellente, Monsieur le délégué du ministère de la Santé publique, Mesdames et Messieurs, il est important ici de rappeler que ces maladies sont évitables à travers l'agissement sur les déterminants de la santé. Il s'agit en l'occurrence de la promotion d'une alimentation équilibrée, l'arrêt de la consommation du tabac sous toutes ses formes, la réduction de la consommation d'alcool constitue en effet une opportunité pour réfléchir, échanger et jeter des bases pour une meilleure implication des uns des autres pour la prévention, les soins et le traitement des affections bucco-dentaires, en renforçant notamment les soins de santé primaires vers la couverture sanitaire universelle promue par l'Organisation mondiale de la santé au niveau global. Nous saisissons cette opportunité pour saluer encore une fois les efforts du gouvernement du Burundi qui a déjà intégré la santé bucco-dentaire dans la gestion d'autres maladies non transmissibles. Nous encourageons les experts dentistes qui se sont mis ensemble dans l'association des chirurgiens dentistes du Burundi. Pour terminer, je voudrais réitérer l'engagement de l'OMS à accompagner, aux côtés des autres partenaires, les initiatives visant à la prévention, le traitement des affections bucco-dentaires et surtout par le biais d'un système de santé renforcé reposant sur les soins de santé primaires. Je vous remercie et bons travaux.
Merci, merci à vous aussi, Monsieur le délégué de l'OMS au Burundi. Je vous invite d'applaudir encore une fois pour son discours. Et je vous invite d'écouter l'assistant du ministre de la Santé publique qui va procéder à l'ouverture officielle des activités du Congrès scientifique de la médecine dentaire au Burundi, édition 2026. À vous la parole.
Madame la province de Bujumbura, Monsieur le délégué du bureau de l'OMS au Burundi, Madame la présidente de l'association des chirurgiens du ministère de la Santé publique et des ministères sectoriels concernés par la santé bucco-dentaire, distingués congressistes, chers professionnels de la santé, chers étudiants, bonjour. Avant toute chose, rendons grâce à Dieu le Tout-Puissant qui qui guide nos pas et nous rassemble aujourd'hui pour bâtir une politique de santé plus forte et plus inclusive. C'est un acte politique majeur et un engagement stratégique fort qui nous réunit aujourd'hui et en ouvrant ce congrès scientifique 2026 au nom du ministre de la Santé publique et dignement empêché, je viens réaffirmer une conviction de l'État. Il n'y a pas de couverture sanitaire universelle sans intégration pleine et entière de la santé bucco-dentaire. Pendant trop longtemps, la santé buccale a été reléguée au rang de soins secondaires. Cette vision est désormais révolue. Face au fardeau des maladies non transmissibles et aux coûts financiers qui pèsent sur nos ménages, le gouvernement du Burundi fait le choix de l'anticipation, de la prévention et de l'efficience. Je salue le leadership de l'Association des chirurgiens dentistes du Burundi et l'appui déterminant du programme national de lutte contre les maladies non transmissibles et de nos partenaires, notamment l'OMS. Une politique publique ne vaut pas par la clarté de ses objectifs et la rigueur de son exécution. Pour concrétiser le thème de ce congrès, le ministère de la Santé publique fixe un cap clair à l'horizon 2028-2030, articulé autour de 4 engagements stratégiques SMART. Premièrement, l'intégration opérationnelle dans les zones de soins primaires. En effet, d'ici décembre 2027, nous intégrerons un paquet minimum d'activités bucco-dentaires, à savoir le dépistage et la sensibilisation, dans 100% des centres de santé publique du pays, en formant au moins un agent référent par structure sanitaire. Deuxièmement, la politique d'éducation et de prévention précoce. En effet, d'ici la rentrée scolaire 2027, en partenariat avec le ministère de l'Éducation, nous déployerons un programme national d'hygiène bucco-dentaire ciblant 80% des écoles primaires afin de stopper la carie dentaire dès le plus jeune âge. Troisièmement, la souveraineté des données sanitaires. D'ici fin 2026, le ministère de la Santé publique mettra en place un registre national numérisé de santé bucco-dentaire intégré au système national d'information sanitaire, à savoir le DHIS2. Ce que l'on ne mesure pas ne peut pas être piloté. Nous voulons des données précises pour rationaliser nos allocations budgétaires. Quatrièmement, le renforcement du capital humain. D'ici 2030, nous visons le recrutement et la répartition équitable de 50 nouveaux chirurgiens, dentistes et spécialistes dans les hôpitaux provinciaux et les hôpitaux des districts afin de réduire la fracture sanitaire territoriale. Chers chirurgiens dentistes, experts et chers chercheurs, vous n'êtes pas seulement des praticiens du soin, vous êtes les architectes d'une réforme structurelle. Je vous demande de faire face de ces 2 journées de travaux, non pas un simple colloque académique, mais une véritable feuille de route opérationnelle. Le gouvernement attend de vos délibérations des recommandations concrètes, chiffrées et immédiatement applicables. Le ministère de la Santé publique s'engage à évaluer vos propositions à travers un comité de suivi conjoint, ministère et ACDBU. Mesdames et messieurs distingués invités, investir dans la santé bucco-dentaire, c'est protéger le pouvoir d'achat des familles, préserver la productivité de notre économie et garantir la dignité de nos citoyens. En renouvelant nos remerciements aux partenaires au développement dans le secteur de la santé pour leur accompagnement aligné sur nos priorités nationales, je vous invite à travailler avec ambition et pragmatisme. Et c'est sur cette note d'engagement politique et d'action stratégique qu'au nom du ministre de la Santé publique, je déclare officiellement ouvert les travaux du Congrès scientifique de la médecine bucco-dentaire, édition 2026. Vive la République du Burundi, vive la médecine dentaire au service du développement, vive la coopération nationale et internationale, vive la santé bucco-dentaire pour tous. Je vous remercie.
Merci à vous, l'assistant et du ministre. Applaudissons encore une fois son discours. Donc, sans tarder, pour immortaliser cet événement, je vous invite à la prise de photos de famille. Et après, nous allons suivre les présentations suivantes. Les photographes, vous nous montrez l'endroit préféré pour la bonne immortalisation de cet événement. On se met où? Là. Donc on enlève ça. Bon, dans la salle, je pense que vous allez vous mettre comme ça. On va prendre la photo. On illustre ça. Oui. Oui. Vous vous mettez ici. Les autres, vous pouvez aller là derrière pour la bonne immortalisation de cet événement. Rapidement pour gagner du temps. Rapidement. N'abariya bari hariya mfise impungenge ko badahava bajamwo. Oui. Abari ngaha turashobora gusanga batagiyemo. Mwebwe muri ngaha turashobora gusanga mutagiyemo. Okay. De la joie, s'il vous plaît, de la joie. De la joie. Merci. Vous pouvez le gagner les places respectives. Et après, j'invite Dr Bonit. Donc, les membres de l'association vers une photo avec l'assistant du ministre. Les membres de l'association, vous allez là. Allez, les membres de l'association, entourez l'assistant du ministre et les autres personnels de marque. Merci. Donc, nous invitons Dr Bonit pour les présentations, pour nous présenter les présentations suivantes. À vous la parole.
Voilà, merci beaucoup pour la parole accordée. Et après ces cérémonies officielles d'ouverture et après ce discours, surtout d'ouverture du représentant du ministre de la Santé publique, pour les orientations qu'il a données et pour justement cette attention accordée à la santé bucco-dentaire dans les priorités nationales dans le secteur de la santé. Nous allons maintenant commencer les présentations par différents conférenciers et nous allons tout de suite inviter le premier conférencier qui est chirurgien dentiste en odontologie préventive et sociale. Et ce premier conférencier a occupé plusieurs fonctions en tant que chirurgien dentiste à l'hôpital militaire de Kamenge pendant 20 ans, de 1996 à 2015. Il a été conseiller du chef d'état-major général en santé pour ce qui est des militaires de 2015 à 2022. Il a suivi également les militaires burundais à la MISOM qui référaient les malades à Nairobi pour les soins médicaux. Et de 2013 jusqu'à maintenant, il est directeur du cabinet privé Kinga et chirurgien buccal dans différents hôpitaux. Il est également vice-président de la CEDEBU depuis 2014 jusqu'à aujourd'hui. Vous avez compris qu'il s'agit d'un militaire. Un militaire est retraité au grade de colonel en 2022 et j'invite Dr Bizimana Athanase pour la première présentation inaugurale sur la santé buccale, un enjeu de santé publique. Bienvenue, Dr Athanase. Merci.
Monsieur le représentant du ministre de la Santé publique et Madame la présidente de l'Association des chirurgiens dentistes du Burundi, ACDBU, Madame la chers collègues, bonjour. J'ai le plaisir aujourd'hui de vous faire une présentation et de montrer que la santé bucco-dentaire fait partie intégrante de la santé générale. Et comme vous le savez, les précédents orateurs ont tous parlé de ça. La santé buccale est l'enfant pauvre de la santé générale. Mais en négligeant la santé buccale, vous négligez sans vous en rendre compte la prise en charge des autres maladies. Surtout parce que 90% des maladies systémiques ont un lien très fort avec les principales pathologies de la santé buccale. Et vous excuserez, ma machine a vieilli comme moi. Elle prend du temps pour s'ouvrir.
Voilà, nous demandons votre patience. En fait, on a un problème technique, mais c'est finalement résolu. Et merci de votre patience.
Et je vous remercie. Et voilà le titre de ma présentation. Et la santé buccale, un enjeu de santé publique. Et comme on l'a dit, moi c'est docteur Athanase Bizimana, chirurgien et dentiste et buccal. Voilà, vous pouvez voir le plan. Il y a quelques définitions. Après, je vais vous montrer que les pathologies bucco-dentaires ont une très grande fréquence dans le monde et dans la région africaine dont le Burundi fait partie. Et les maladies, les affections bucco-dentaires sont aussi très graves. Après, je parlerai brièvement de la santé buccale. en 2025 au Burundi. Après, nous parlerons des propositions de la CEDEBU. Et en m'arrêtant un peu ici, je remercie en passant le délégué du ministre de la Santé publique parce que toutes les propositions que la CEDEBU allait faire ici, elles ont déjà trouvé des réponses. Il y a déjà un plan pour ça. Après, c'est la conclusion. Voilà la définition de la santé buccale selon l'OMS, absence de douleur faciale, buccale ou faciale, de cancer de la bouche, de la gorge, et de maladies du parodonte, la perte de dents, absence de perte de dents ou d'autres affections de la cavité buccale et du complexe crânio-facial. C'est un état qui permet à l'individu de vivre normalement, parler, manger, sourire, en toute confiance. Sans bouche en bonne santé, il n'y a pas de santé générale. Voilà, selon toujours l'OMS, la santé publique est l'art de prévenir les maladies, de prolonger la vie et de promouvoir la santé par le biais des efforts organisés de la société. Pour la santé bucco-dentaire, la santé publique, c'est passer du soin individuel au niveau du centre de santé à une politique nationale avec un plateau technique dans tous les paquets minimum d'activités. Les affections bucco-dentaires sont très fréquentes. Et c'est l'une des raisons pour lesquelles elle constitue un problème important de la santé publique. Et ces affections sont les principales affections bucco-dentaires. C'est d'abord la carie dentaire. Le délégué du représentant de l'OMS l'a déjà dit. En 2025, l'OMS a recensé 3,7 milliards de cas dans le monde. C'est-à-dire que 3,7 milliards de personnes touchées par la carie dans le monde sont traitées. 2 milliards et demi de cas. C'est 1 milliard de cas de plus que le diabète, les cancers, les maladies cardio-respiratoires réunis. Selon l'OMS 2025, les affections bucco-dentaires constituent un fléau mondial. La deuxième maladie, la deuxième affection bucco-dentaire la plus importante, c'est bien les maladies des gencives, les maladies du parodonte. Le parodonte étant le tissu de soutien des dents, la gencive et l'os sous-jacent. Observez ces chiffres, s'il vous plaît. 1 milliard de cas de maladies parodontales sévères et plus 1 milliard de cas en 30 ans. Il y a d'autres maladies, d'autres affections bucco-dentaires, c'est notamment la perte de dents, les cancers de la cavité buccale, le traumatisme et le noma. Je dois affirmer ici devant vous que durant 30 ans d'exercice, de profession, de ma profession, je n'ai pas encore rencontré un seul cas de noma au Burundi. Peut-être mes collègues qui travaillent à l'hôpital Prince-Régent et le roi Khaled peut-être ont déjà rencontré ces cas. Les affections bucco-dentaires sont évitables, notamment par la prévention. Elles constituent pourtant un problème de santé publique de par leur fréquence très élevée et leur gravité. Et dans la région africaine, selon toujours l'OMS, 10% des affections, et 90% des affections non traitées. L'accès aux soins dans la région africaine dont fait le Burundi, c'est entre 21 et 64% selon les pays. Voilà. Ça, c'est une maladie. Ça, c'est la carie dentaire. La gingivite de grossesse, ça, c'est une des maladies du parodonte, du tissu de soutien des dents, et qui s'aggrave avec la grossesse, quand évidemment il n'y a pas une bonne hygiène bucco-dentaire. Ces cas-là, on les voit presque tous les jours. Regardez alors maintenant une parodontite, là, l'os de soutien des dents a déjà été touché. Regardez ce qui se passe. Il y a même perte des dents. Les dents chutent. On a toujours vu quand on était enfant, chez nos grands-mères, quand elles essayaient de couper un morceau de manioc, une dent tombait. On ne savait pas. Ça, c'est la parodontite. Voilà, parlons maintenant de la gravité de ces affections. Selon toujours l'OMS, la région afro, donc la région africaine de l'OMS, on peut voir que les caries dentaires, ils provoquent des douleurs, des absentéismes scolaires, et 60 à 80% des enfants de 12 ans sont touchés. Les maladies du parodonte, chez les diabétiques, ils causent des accouchements prématurés et des bébés de faible poids. Le cancer buccal, qui est lié au tabac, à la chic, à l'alcool, le cancer buccal est le premier cancer des voies aérodynamiques supérieures, donc le cancer buccal de l'ORL en Afrique. Les traumatismes qui provoquent souvent des édentations, des pertes de dents. Ils provoquent des malnutritions, ils provoquent de l'isolement social. Ça se remarque chez les personnes très âgées, mais aussi chez les jeunes. Toujours en parlant de la gravité de ces affections bucco-dentaires, nous allons vous montrer le lien très important qui existe entre la santé buccale et la santé générale. 90% des affections systémiques qui sont souvent classées dans les maladies non transmissibles, ils ont un lien très fort avec la santé buccale. Le diabète, par exemple. Le diabète et la parodontite, donc l'affection du tissu de soutien des dents. Ça s'influence chacun. Quand la glycémie monte, la parodontite s'aggrave et inversement. Tout avec les caries. Quand il y a infection, donc une carie non traitée, et qui évolue vers la cellulite, dès qu'il y a infection, la glycémie monte. La grossesse et la gingivite étant l'inflammation des gencives. Là, l'os de soutien n'est pas encore touché. Mais malgré ça, il y a un risque très accru d'accouchement prématuré et d'accouchement de bébés de faible poids. En cardiologie, ce qu'on appelle l'endocardite, par exemple, d'Osler, l'endocardite infectieuse, il y a 40% de points d'entrée, c'est dans la cavité buccale. 40%. Donc, en traitant la cavité buccale, on peut éviter 40% d'endocardite infectieuse. Les bactéries buccales provoquent aussi des AVC et des décès. La nutrition, le VIH. La bouche est souvent, la bouche peut servir souvent de diagnostic précoce de ces maladies. Parce que, par exemple, les candidotes, les stomatites, parfois, en examinant seulement la bouche, on peut déjà suspecter le VIH. La haute tension artérielle, les leucémies, tout ça, la bouche, en se basant seulement sur la bouche, on peut déjà suspecter ces maladies. La santé buccale n'est donc plus un luxe. C'est une composante de la couverture de santé universelle. Ça, c'est l'OMS qui le dit en 2022. Parlons de la santé buccale au Burundi. Parlons des défis de la santé buccale au Burundi. Excellences, distingués invités et chers collègues, savez-vous qu'on n'a pas de données nationales sur la santé bucco-dentaire au Burundi en 2026? Et pourtant, cela est une réalité. Ce qui fait qu'on n'a pas de politique de santé bucco-dentaire déjà adoptée. Il n'y a presque pas de prévention des affections bucco-dentaires dans les écoles, à part quelques actions de la CDBU et d'autres associations sœurs à la CDBU, notamment Riprosad et SMOM. La santé bucco-dentaire n'est toujours pas intégrée dans les soins de santé primaire et dans le paquet minimum d'activités au niveau des CDS. Il y a un manque criant du personnel qualifié en santé bucco-dentaire au Burundi. J'ai estimé qu'il y a à peu près 40 chirurgiens dentistes et 40 techniciens supérieurs en odontologie pour 12 millions d'habitants. Avec ça, il y a une répartition inégale du personnel et des services. Au Burundi, il y a à peu près un dentiste pour 150 habitants, quand l'OMS recommande un dentiste pour 5500 habitants. Parlant des défis, toujours des défis de la santé bucco-dentaire au Burundi, selon toujours l'OMS, 70% de la population burundaise n'a jamais consulté de dentiste. Il existe un déficit important des services de santé bucco-dentaire, ce qui explique qu'il y a un accès limité aux services et aux équipements. Il y a l'inexistence des écoles de formation. Actuellement, on peut féliciter l'université d'Ongozi qui forme toujours la seule institution universitaire au Burundi qui forme actuellement des techniciens supérieurs en odontologie. Mais il y a tout de même quelques atouts. Et nous l'avons vu tout à l'heure lors du discours du délégué du ministre de la Santé. Il y a une volonté politique affichée. Ça, c'est un atout. En discutant ici et là avec les représentants des organisations internationales, et le délégué de l'OMS vient de l'affirmer tout à l'heure, il y a aussi cette volonté des organisations internationales comme l'OMS et l'UNICEF. D'autres atouts, c'est les associations pour la promotion de la santé bucco-dentaire, notamment la CDBU, Dentaire, il y a Iprosad, SMOM. Un autre atout, c'est l'existence des mutuelles et des partenaires privés et le coût de l'inaction. Quand on n'agit pas en santé bucco-dentaire, par exemple, et pour le patient, une dent s'arrache dans les hôpitaux publics à 30 000 francs, alors qu'il pouvait être plombé, ce qu'on dit plombé dans le langage courant, alors que la carie pouvait être soignée à 5 000 francs. Le système aussi perd, parce qu'il y a augmentation des urgences, il y a utilisation accrue des antibiotiques, de l'hospitalisation, des arrêts de travail et un accroissement des dépenses de l'État. Pour les enfants, n'en parlons même pas. Il y a des douleurs, l'échec scolaire et la pauvreté des parents. Selon l'OMS, $1 investi en prévention égale $8 économisés en soins par les pays. Parlons un peu du bilan. Le bilan sommairement, parlons sommairement du bilan de l'ACDBU durant ces 10 années d'existence officielle. L'ACDBU a mené des campagnes de sensibilisation dans les écoles et les prisons de la capitale. Et nous avons, la CDBU a participé à la formation des chirurgiens dentistes, nos collègues, à l'Université Hope d'Afrique, et à la formation des techniciens supérieurs en odontologie à l'INSP et à l'Université d'Ongozi. L'INSP a fermé malheureusement cette filière. Et la CDBU est organisation du public et à la prise en charge des personnes âgées. Et la CDBU participe aussi dans des congrès et en a organisé un aujourd'hui. Et puis la CDBU fait un plaidoyer auprès du ministère et des partenaires pour intégrer la santé bucco-dentaire aux soins de santé primaire et au paquet minimum d'activité, c'est-à-dire pour l'approche globale du patient. On trouvait déjà une réponse d'après le discours du délégué du ministre de la Santé publique, mais permettez-moi de les rappeler. Il y avait premièrement la prévention. Le gouvernement, via les ministères chargés du commerce ou le ministère chargé des pharmacies, peut exiger la vente que seuls les dentifrices fluorés se vendent au Burundi. Sans beaucoup de moyens, sans utiliser beaucoup de moyens, on peut aussi faire l'éducation pour la santé bucco-dentaire dans les écoles, à partir même de l'école maternelle. Deuxièmement, une enquête sur la prévalence des principales affections bucco-dentaires. Après, permettre l'accès aux soins bucco-dentaires de la population burundaise, c'est notamment en créant des postes dentistes dans chaque district sanitaire. Il y a aussi l'intégration du plateau technique dentaire OMS dans le paquet minimum d'activité de tous les CDS. La formation. Former plus d'assistants dentaires et de spécialistes, des agents de santé et des enseignants au dépistage. En politique, on peut toujours taxer le sucre, interdire les publicités et la vente des sucreries, donc les bonbons et sucettes, et pour les enfants dans les écoles maternelles. Vous avez toujours vu, et certains parmi nous, quand nous allons récupérer nos enfants dans les écoles maternelles et primaires, nous avons toujours tendance à leur acheter des sucettes, sans savoir que c'est l'une des causes des caries rampantes que vous avez vues plus haut. Le gouvernement peut interdire cette vente. Et puis, favoriser le partenariat entre l'État, les ONG, les privés et les mutuelles. Tout ça a déjà trouvé une réponse. Et je vous remercie pour votre écoute.
Merci au présentateur pour sa présentation qui était riche et qui nous met dans le bain de ce congrès scientifique et dentaire. Vous avez compris que finalement la santé buccale est un enjeu effectivement de santé publique vu les chiffres qu'il nous a présentés. Il a présenté aussi pas mal de défis dans ce domaine, mais aussi il y a un certain nombre de recommandations qu'il a formulées pour terminer. Et effectivement, je trouve que sur le programme, on va de poursuivre avec les autres présentations. Sinon, je vous invite maintenant à prendre une pause café. C'est à -2, donc au-dessus de ce niveau. -2, nous pouvons aller avec ascenseur ou avec escalier. Et après la pause café, nous allons visiter les stands. Et après la visite des stands, nous allons revenir dans la salle pour la suite. Voilà, merci beaucoup et bon appétit pour la pause café. Voilà. Et nous allons prendre maximum combien? 20 minutes. 20 minutes pour la pause café et consacrer 15 à 20 minutes aussi pour la visite des stands. Je pense que nous allons récupérer quelques minutes qu'on a perdues au démarrage. Merci beaucoup. Vous pouvez guider, vous pouvez suivre ce monsieur là-bas pour la pause café. Hein. comment est-ce que le ministère prévoit intégrer les soins de santé dentaire au niveau du paquet minimum d'activité, au niveau des centres de santé. Par exemple, ici, je vois docteur Jean-Claude qui représente le programme, peut-être va aider pour répondre à certaines questions, certaines interrogations. Donc, il est 11h40 sur ma montre pour quelques 10 minutes seulement d'échange par rapport à la première présentation. Si tu as été compris, une observation ou je ne sais pas, hein, une contribution pour pouvoir avancer. Hein? Parce qu'en fait, ce congrès scientifique dentaire, c'est un point de départ pour action. Pour action, il faut agir à tous les niveaux, il faut agir au niveau du ministère, il faut agir au niveau du programme. Est-ce qu'il y a une observation? Est-ce qu'il y a un commentaire? Bon, s'il n'y en a pas, je pense on peut avancer avec la présentation qui va suivre. Mais quand même, il devrait y avoir pas des observations, des commentaires. Je vais donner la parole à Dr Jean-Claude pour peut-être quelques éclaircissements par rapport à la présentation, par rapport aux défis, par rapport aux recommandations.
Bon, je crois que les défis seront également repris lors d'une présentation de domaine qui sera présentée par le programme national de lutte contre les maladies non transmissibles. Mais j'ai été intéressé par un point qu'il a relevé. Donc d'abord, c'est quelqu'un qui travaille depuis longtemps en médecine bucco-dentaire. Je crois qu'il a formé presque tout le monde qui est ici. C'est tout le monde qui est intéressé par la médecine dentaire. Et il a parlé que dans l'exercice de son métier, il n'a jamais rencontré un cas de NOMA. Alors, le M n'existe pas. Ou bien, ils sont traités ailleurs. Est-ce qu'il y aurait quelque chose qui empêche que les gens consultent pour le NOMA, s'il existe vraiment? Il y a des soins qui sont offerts, mais ce sont des soins qui ne sont pas bien intégrés, avec l'absence de protocole. Parce que nous avons trouvé que, comme on va le présenter demain, beaucoup de cas dentaires sont traités par extraction. Donc, ce qui veut dire qu'il n'y a pas une standardisation des protocoles. Donc l'intégration des soins est un de lutte contre les maladies non transmissibles et que les réformes récentes au niveau du ministère ont fait qu'il y ait une création d'une série chargée de la santé bucco-dentaire. Cet engagement politique est là, donc il faut que cet engagement politique soit traduit. On pose des actes qui ne sont pas standardisés. Merci.
Très bien, il y a Madame Sanitaire. Merci.
Merci de m'accorder la parole. Par rapport au c'est Dr Anezima Nirakiza, chirurgien dentiste. Par rapport à cette pathologie, ces gens-là existent et visitent souvent les hôpitaux publics. Ce sont des cas très difficiles à traiter parce qu'il y a une perte de tissus mous et des tissus aussi osseux. Et souvent, ça nécessite une reconstitution, à la fois une greffe au niveau des parties molles et une greffe osseuse. Les complications de ces enfants sont vraiment graves parce qu'il y a une défiguration de l'individu et surtout un enfant de bas âge parce que jusqu'à présent, il y a des cas qui puissent être documentés et pris en charge. Il y a aussi des adultes qui sont mal nourris et aussi présente le NOMA.
Il nous reste quelques 5 minutes seulement pour nos échanges. Donc, je donne la parole au président de la CDBU.
Kanshimye ko kwiyexprima mu Kirundi kuko kare bavuze ku kintu kijanye na data information akenewe muri santé bucco-dentaire, kuvuga bariko barakorana na Budental Mission mu ma activité iriko irarangurira intérieur. Dufise objectif yo kuvura abantu bashika 500 mu ruguru. L'année prochaine ntibazosubira kuvuga ko ata madone bafise kuri santé bucco-dentaire mu Burundi. Rero nkuko babivuze barafise politique yo gushaka gushigikira ko ibikorwa vya santé bucco-dentaire cyangwa igisata ca santé bucco-dentaire gitera imbere. Natwe dushaka kubabwira yuko tubashimiye ku byo bariko baragerageza gukora vyose. Murakoze.
Voilà, merci beaucoup. Il y a quelqu'un qui a demandé la parole. Je pense que c'est le dernier, hein? 1 minute.
Merci beaucoup, docteur. Bon, je ne devrais pas me parler parce que c'était en rapport avec les données. Les indicateurs, il y avait aussi les indicateurs liés à la santé bucco-dentaire. C'est comme une interpellation aux collaborateurs que vous êtes. Donc, c'est vrai, on peut faire des enquêtes pour faire la collecte des données, mais si ces données qui sont collectées à travers les centres, les cliniques qui s'intéressent à la santé bucco-dentaire sont collectées, ça peut quand même renseigner à quelque chose. Donc, c'est comme une interpellation aux acteurs, aux collaborateurs de collecter et aussi de renseigner
Merci de m'accorder la parole. Et je voulais seulement ajouter en ce qui concerne le NOMA, et je pense que l'enquête devrait se faire dans les milieux défavorisés. Parce que comme ma consoeur l'a dit, c'est une maladie qui touche principalement les enfants malnutris. Et souvent, ils se rencontrent dans les camps de réfugiés.
Nous allons enchaîner avec 3 présentations ou 4. 3 présentations. Une présentation sur les instruments de chirurgie buccale orthodontique. Le prochain présentateur que nous avons spécialisé en médecine du sport. Ensuite, il a obtenu son diplôme de doctorat en Doctor for Dental à la State University of en 2011. Après ses études en médecine dentaire, il a consacré 2 années à exercer au service d'une communauté défavorisée à Albuquerque. C'est au Nouveau-Mexique. En 2013, il a eu son cabinet dentaire où il exerce jusqu'à présent à Mesquite dans le Nevada. Et il offre une gamme complète de soins dentaires avec un intérêt particulier pour la chirurgie bucco-dentaire. Pour ne citer que cela, et sa biographie est riche. J'invite Dr Marchand David pour nous présenter les instruments de chirurgie buccale.
Thank you very much for that introduction. Can you hear and understand me? If you can, touch your nose. Okay, so some of you understand what I'm saying. Okay, before I forget, there's something I always wanted to do. Could everybody please stand up? Real quick, stand up, everybody. Okay, I'm going to stand up here. Now, if your birthday is within the months of January, February, March, April, May, or June, I want you to go like this. Okay? Now, if your birthday is not in those months, but it's in the other months, I want you to go like this. Very good. Hold on. Thank you. Now I can tell my wife and kids I got a standing ovation. Okay, you can sit, please. Okay, so one of my favorite things to do, oh, first of all, I'm not going to use, my favorite thing to do in dentistry is extractions. And it's always been that way. When I was in dental school, I went on dental missions. I went to Ghana, I've been to Mexico and other places, and we just pulled teeth. And during those trips, I had an oral surgeon along with me, and he was teaching us some of his techniques. So I feel like I really love extractions. So we're going to talk about dental instruments and how to use them. In my dental office, I got 6 operatories, 6 chairs. I work out of 3, and then I have 2 hygienists, and they work out of the other 3. And so I'm able to schedule my office time efficiently, so we can see a lot of people in a day. And one of the things that I don't worry about is extractions, because I only have a few instruments that I use. I don't have a drawer full of instruments and do all these fancy things. You can pull teeth very easily and fast with just a few instruments. And so I'm going to go over some of those real quick. Oh, this is 3 beautiful girls from up in Kirundo area, from here in Burundi. So back in 2021, me and my wife adopted 2 girls, one of which is Ange. She's here. We say Ange in America. Brought her with us. She wanted to come back to her country and see people and try to find some family. And then Odette is the girl. So in 2021, we adopted Ange and Odette. And then a couple years later, my wife came to me and said, we need to adopt another one. And I'm glad I did. We got Clementine, and she's the one that's being held by my wife. And then we'll go through. We got, my oldest is Maya, Elsie, Mason, Odette, Ange. A couple of all the interesting things that I like to do for fun. Okay, so I went to Southern Utah University. I majored in sports medicine. Decided I wanted to do dentistry. I enjoyed the aspects of giving shots and stitches and x-rays. I went to dental school in SUNY, Buffalo. SUNY stands for State University of New York, Buffalo, New York. Okay, so a couple things about it might be a little bit higher. 31.7% of people age 5 plus untreated caries and permanent teeth. So they're getting cavities at a young age. 19.2% of people age 15 plus had severe periodontal disease. We know periodontal disease, for the most part, is completely preventable. Most dental problems are preventable with proper oral hygiene and education on what to eat, what causes it. 22% of people ages 20 plus were completely edentulous, meaning they have no teeth. And the World Health Organization reports the density of dentists in Burundi as 0.01 dentists per 10,000 people. I imagine in Africa you're getting a lot of people that don't go to the dentist until there's a problem. And at that point, you're looking at extraction. I'm a member of the church, and in our book of scripture, we believe in the Bible as well as a book called the Book of Mormon. This is a scripture from the Book of Mormon, and it was a quote from a king that was a leader of a large group of people. And as a king, he didn't take any kind of, he was in the service of everybody in the country. He didn't take people's money to support himself. He supported himself and served other people. And that's a lot of times what you dentists do in your community. He said, this prophet, the prophet's name I believe was Benjamin. He said, when you, or ye, are in the service of your fellow beings, ye are only in the service of your God. And I know that people here in Burundi, they are the heart of Africa. Rwanda thinks they're the heart of Africa, but I think you... Okay, so like I said, this is a... I need to move to a better location. I might rain by maybe. But I set up to do when my assistant set she just instruments. We good? Testing, 1, 2, 3. You got it. Okay. So here's some basic principles of tooth extraction. First off, you want to examine the tooth and the surrounding tissue, the root shape, everything, what's been done to it in the past. And then you also need to tell the patient what to expect. So when I have a patient, if I'm talking popping sound, and then I usually throw a joke in. I said, if you might hear a dog barking or a cat meowing, that's all normal, okay? And that kind of breaks. Okay, and then you want to be able to instrument. You want to elevate the tooth with an elevator before you use the forceps. You want to know the anatomy and what's around the tooth. And also very important is you want to avoid excessive force. Excessive force can cause problems. I think back in the day, a long time ago, they used to teach in dental schools probably more force the better. And I heard stories too about dentists. They have a patient in the chair and they can't get that tooth, so they use little forces. And if we can get a purchase with our instruments, we can loosen those teeth up easily without force, too much force. Okay, here we go. We're going to skip that. We kind of went over that. Okay, so basically the goal of extraction, you have a tooth that's locked in bone. And that bone is attached to the root through ligaments. So we want to break those ligaments and then we're going to squish the bone. We actually break the bone and compress it to create a space for that root to wiggle and move and essentially come up out. Okay, so you're using force to break the bone and break the attachments of the tooth to the bone. My favorite instruments right here. This is basically what I use. I have an east-west. Sometimes they're called criers. Okay. A spade elevator. That's the right name. Okay, so you want to use these instruments to loosen and mobilize the tooth and to grasp it and pull it out, just like the concept is, like I explained. Gain a purchase. That's why we use our elevators. And it's going to luxate the tooth, meaning it's going to push it and crush it against the bone and release the... All right. Okay, do you know what... I don't think many people have trampolines. Trampolines in America, they're in almost most backyards. My kids have one. I grew up on a trampoline doing flips. A trampoline has springs on it. These are springs. And as you jump, those will go like this, and it cushions you as you jump up and down. Okay? Our teeth have what's called ligaments. They're like springs on a trampoline. So when you bite, it cushions everything. So you're not hitting bone. That's not good. So the periodontal ligament are like springs on a trampoline. We're going to break those. Okay. Now with, I start out with space. Space right there between the bone and the roots, the periodontal ligament space. It's starting to get wide right there. And I can get a purchase for force right there with a spade elevator. And that root is pretty straight and tapered, so I don't think that's going to give me it's a lot easier. But with spade elevators, they're dangerous. It's like a weapon. you could probably kill somebody. If so, this is how I hold my spade elevator. I hold it like that. So if I'm applying pressure and I try not to put too much pressure, I wiggle it to try to get that tip between the root and the bone. And when I can feel that it's kind of in it, then I start to twist it. If you push too hard and you slip, you're going to have a problem. Like that. I did that to this guy with a spade elevator. Thank goodness he thinners normally, but he got off of them. And I didn't even, I was taking out a premolar, infraorbital bone, okay? It gave him an infraorbital fracture. And he started to bleed inside his tissues. It didn't have a way to escape into his mouth because I didn't break the tissue. And I called the oral surgeon friend. I said, I got a problem. He's like, well, just try to put pressure on it. But how do you put pressure on that? I just careful with those spade elevators, but they are amazing. Okay, I also use a curette and a rongeur. Not many instruments. When you're pulling out a tooth, it's also important to clean the socket once that tooth is out. Every Sunday would make Jello for us. We loved it. You're going to find Jello in someone's mouth, but it's not Jello that you eat. It's granulation tissue. You want to get that out. Okay, so tooth number 30, let's analyze. Whoa. We're going to analyze this. I think it skipped ahead on me. Okay, so I'm going to be taking out tooth number 5. And I hope I got Wi-Fi. That's good. Number 5, if you look at it with me, it's severely decayed. Do you think that tooth is going to be able to hold up to an elevator pushing against it? What do you think is going to happen? It's going to break. It's going to break right to the gum. And then, so let's see what's going to happen. Good thing is the root is tapered, so it doesn't look like it's locked in bone. Because sometimes if a tooth is bent like this, it's locked in bone, and it's hard to get out. At the tip, there's an infection at the tip of the root. So we're going to be getting some granulation tissue out of there. Sorry, I'm trying to get, it was working earlier. Aha. Okay. This video, the first one's just kind of grainy. I apologize. Grainy meaning it's not clear. What I'm doing is I'm going through my spade elevator and I go through the mesial because the distal had a lot of decay. I hold my finger on the buccal and the palatal on both sides of the teeth so I can feel the bone moving and the tooth moving and protect the patient if it slips. My fingers are there to kind of stop it from slipping. Okay, it broke. Now you got all this decay. So I use my spade elevator to try to get leverage between the root and the bone. There we go. And I'm not doing much pressure. Very little pressure. The last thing I want to do, in dental school they taught me, oh, if this happens, just get a burr and cut out the buccal bone. Cut out the bone on the side. And I've come to realize that is not a good idea. The last thing I want to do is cut out buccal bone. And the reason why is because if you cut out buccal bone, you're opening a whole lot of opportunities for complications with healing, and they're going to have a lot more bone loss. So I'm just creating space. I'm crushing the bone with that spade elevator to create space. Okay, I keep my finger on the buckle so that I can feel the bone. The bone's talking to me. If you're listening with your fingers, nope. I only use an ash on anterior and premolar teeth. Okay? They didn't feel it. They didn't feel a thing. So now I'm getting a curette. I'm going to start scraping out the granulation tissue, the infection, the jello. I'm compressing the socket with my finger. So when you pull a tooth, the bone that surrounds it breaks like this. Okay? It's like getting a stick. It's like getting a stick and breaking it just a little. Infected gums. If somebody's coming to you to get a tooth extracted, do you think they're probably going to have some sort of gingivitis or periodontal disease around that tooth? Almost 100%. One of the most common diseases of the mouth, the most common disease of the mouth is gingivitis. Just swelling of the gums. Everybody here's probably got it. Okay? If it gets advanced, it's periodontal disease. You don't want infection in the gum around a socket that is trying to heal. That can cause problems. So I go through with my my rongeur, and I start clipping out the gingiva to get rid of the bad infected gums. And then I suture them up. I also use the curette. So a lot of times people use a periosteal elevator. I rarely use a periosteal elevator. Sometimes, but rarely. I use my curette. And what I do is I put that curette between the bone and the extraction site, and I detach the gums from the bone so that I can get the gum to stretch, so I can close that extraction site with sutures. Here we go. That's had a root canal is really, really weak, and it breaks easily. So before I even get into this extraction, I look at the x-rays, I evaluate it. It looks like they have a long-standing infection. You can see that there's a radiolucency and opacity a little bit. So, and there's maybe a little bit of space on the front side of the root, or the mesial of that root, where I can get my spade elevator in there, get some space, start moving that tooth, break the trampoline springs. I got my favorite instrument, and I use a rongeur and a curette. That's it. I have my finger on the buckle just so I can feel the tooth move and the bone move with it. I'm not pushing hard, I'm just getting a little bit of space between the root and the bone with that spade elevator. And I advance it down into the bone to create space. Does this make you hungry? Does anybody want to eat? Come on, come on. Check the root, make sure it's there. Nice. the socket, curette, also known curettage. Is that French? That's French. And rangeur, is that French? I know French. Curettage. Yeah. All right. One of the most satisfying things as a dentist, and this is weird. If you like this, you're a dentist, is pulling out infection. All that granulation tissue, it's coming out, and you're just grabbing it, and it's getting slurped up into the straw. I don't know. I love that stuff. Okay, rongeur to pull out any infected gingiva, the gums at the between the teeth. Ooh, look at that. Okay, and then I suture them up, send them home. All right. Another instrument that gets me out of a lot of tight situations. So when I was in Mexico in dental school, I was pulling out a molar on like, I don't know, a lower molar. And we pull it out and 2/3 of the tooth comes out. So there was one root in there. And we were like, oh my gosh, dental students, we worry about stuff like that. And we looked at each other. I had a dental student with me, and we're like, what do we do? What do we do? And we went to the oral surgeon and said, hey, what's this? He looked in there, and he looked up at us, and he's like, he went and grabbed an east-west. He came back, and it was out, just like that. And then I learned the east-wests are awesome. Okay, so this says that. Okay. And then there's forceps. These are some of my favorite for molars. We're going to get into some forceps. Okay, one of my favorite forceps is the cow horn. And the way I remember it is Michael Jordan. I know you guys know who Michael Jordan is. I see about 3 or 4 people with his jersey on in the streets when I'm driving around. Number 23, the cow horn, is my Michael Jordan forceps. Okay, it looks like a big cow, you know, and he's got Michael Jordan's number. It's the number 23. That's what we call it. So if you're going to order a cow horn forceps for your office, you'll call up the rep and say, I need a number 23 forceps. If you say I need a Michael Jordan forceps, he probably won't know what you're talking about. And then so you use, I like Michael Jordan. I like number 23 on molars that have split roots. They're not close. This has roots that are close. These roots are split. The cow horn is designed to pull out molars that have splits like this. Those wrap around and go into the bone and pinch this area and lift it up. Okay? This root looks like it's got a little bit of a bend to it, so this root is stuck in the bone. It's like tight in bone. It's going to break, probably. This one's straight. AKA stands for also known as. Anyways, I tell my assistant, I need the go-getter. She goes and gets it. A go-getter is a hustler, a self-starter, an achiever, a doer. So anyways, all right, so right here we got 2 teeth have had root canals. This one has a post in it, so I know that's going to break. It's very weak. Got infection at the tips. Cow horns would be good. This one here is the one I'm going to show you. This patient has a deep probing depth, an infection. I put my perio probe in there and I bury it at 10 plus depth. This one can't be saved. The front root, look at the front root. if you can imagine, if you hold your hand up like this, and you got this cup in your hand, that thank you. It's had a crown, so it's been cut down, but it doesn't look like. So I use my elevator. That's probably my skinny straight. That's what I call it, skinny straight. Just leaving it, I twisted the elevator, and I just leave it right there for a second, just so it crushes the bone. And then blood is going to rush to that area, and that also helps loosen the tooth. Now watch, I'm holding the, now I got my spade elevator, and I got my finger, I'm protecting the patient, and I'm feeling the tooth move. So I got my thumb on the tongue side, my pointy finger on the cheek side, and I'm twisting the elevator. And I can, the bone is talking to me. See, it lifts just a little bit, and down. Okay, here comes Michael Jordan. I'm going to put force on the head of that forceps and push it down into the furcation, or where the root splits. Force those down there. See? And then with my other hand, I don't squeeze that hard, but I do rock it up and down and do force at the head of the forceps. And that lifts it. There's bone, and this root is stuck in bone. So I'm going to have to remove the bone between the roots to get to the root, to pop it up and out. Here it comes. Oh, it's crowning, and it's a boy. It's going to be satisfying. And do you like this? No. Only dentists like this. Oh, here it comes. I'll grab my rongeur, pull it out with my rongeur, and then slurp it. My curette, I'm going to go in and scrape that infection. And right now I'm using the curette to dislodge or to break the gums off of the bone because I'm preparing to suture it closed. And I want it to close all the way. So it's important those gums are loose. By the show of hands, how many people have problems here in Africa with dry socket or infections after extractions? I guess you are from Africa. It's you know, Egypt, that's Africa. In America, we do too. Infections, dry sockets, and I don't want to see the patient back after I pull their tooth. I got their money already. if I see him again, I'm probably not going to charge him. Okay, so we're going to go over some things we can do. We're going to go over something, nickname that I use. I just say 88, or I just say I need upper right or upper left. That's why they have 88L, 88R for left and right. And this is designed to be able to grab the roots, because the upper molars, these are for upper molar teeth. The 88s are for the upper molars because there are 3 roots generally, okay? And so the design of the forceps is so that it can grab between, it'll grab the palatal root, the root on the palate, and then another one that'll go between the distal and the mesial root, okay? And then you can luxate it back and forth. Here's a quick demonstration of how to use that. I couldn't get a good video of that, but this one is. This will do it for you. Okay, you see the design, how it's got between the mesial buccal and distal buccal and the palatal root. Boom, done. Okay. I'm going to be taking out in this tooth number 2 and 3. If you look, tooth number 2 and 3 have both had root canals. So right there, you know it's going to break, probably. It's got recurrent decay or cavities under the crowns that are there, here and here. And then if you look, you can see the core buildup. There's a big filling underneath that crown, which tells me there's not much tooth structure that's solid under this crown. Same with this one. It's a little bit better than this one from what I can tell, but there's a better picture. I mean, there's just a shell, a thin shell of tooth that's holding that crown in place. So if I put pressure on it, count on it breaking. Okay, so let's see what happens. Got my spade elevator. I'm going to put it between 2 and 3, see if I can get some leverage. And not much pushing. What happens? So the distal, that number, what is that, number 2, broke. Okay, just like I thought, the crown's broke. Okay, this is the same tooth, different view. I'm going to use the 88R, try to grab the crown. I push it below, under the gums as far as I can, and there you go, it broke. Expected. I'm going to go see what else I can get. I think I got the palatal root on that one. I grabbed the forceps that don't have the prongs. They're not split. Can't remember what that's called. And it broke. Okay, so now on the upper molars, you can cut the roots in a Y shape. And that's what we're going to do, to just like that picture showed, that Y pattern. So I'm going to go through, cut the Y pattern, and take the tooth out root by root. Okay, you see that? Can you see that very well? Yeah? Okay, it's been cut just like that. Now I can go in with my favorite instrument, which is the spade elevator. Loosen their sharp bones, so I use my rongeur to break the sharp spade, and then I grab my rongeur, grab out the palatal root. Maybe that was the mesial. I'm going to use the rongeur to remove the buccal bone because it's sharp and loose. If you leave that in there, that's going to start to come to the surface and it'll hurt the patient. So just take it out. I'm taking out the bad tissue that's infected, and then I'm going to suture them up. Goodbye. See how loose that is? So now I can suture it up and close that space. Okay. Okay, so now we're going to talk about platelet-rich fibrin. If you've heard of platelet-rich fibrin, raise your hand. Anybody heard of that? Okay, platelet-rich fibrin is something that I incorporated in my office a number of years ago because I was having people come back with dry sockets. My bone grafts were failing. Bone grafts, you're just asking for an infection. Okay, they're just so prone to infections. So I started out realizing the bone graft alone is not good. You need a lot of blood in it. So I would try to get a periosteal elevator or a spoon, like a curette, and I'd pick up the blood in the person's mouth, the patient's mouth, that had clotted, and I'd mix it with my bone. And I'd put that in the mouth, and that helped. But it still wasn't great. So I decided I need to just figure out how to do this, and I did. It wasn't perfect. When you do it, it's going to be an experiment because the machines aren't standardized around the world. And I'll show you what that means. Okay, so the process, platelet-rich fibrin. So what is PRF? The process, so you take a small amount of blood and you spin it in a centrifuge. A centrifuge spins blood, separates it. There's no additives, it's all natural. It contains a high concentration of platelets, white blood cells, and stem cells inside of a web of fibrin. And what it does is it has a scaffolding. It creates a network that breaks down slowly. It releases growth factors, and gradually, over a long period of time, it dissolves rather than all at once. And it's really good with your tissue and healing. So these are the things you need. You're going to need some that you can draw blood into, okay? You're going to need a tourniquet. Maybe you need a kit on the upper corner, a kit. I bought a kit, but I don't use most of the parts. You're going to need a centrifuge. You can buy those from China for cheap. And then you're going to need a needle to draw the blood, okay? And after you spin it, it's going to separate the red blood cells from what's the plasma, and right here between the two, there's going to be platelets, white blood cells, stem cell type cells. And we're going to take this and make something with it. You can make what's called sticky bone or PRF membrane. Okay, sticky bone or PRF membrane. Okay, so what I do is I draw 4 vials of blood. I centrifuge it, all 4, for 3 minutes at 1,300 revolutions per minute. And it's different for the centrifuge that you have. So after 3 minutes of spinning, I take 2 vials out and I suck out the plasma and the white blood cells, and I mix that with the bone, okay? And then the remaining 2 vials of blood, I put back in the centrifuge, and I spin it again for another 5 to 10 minutes. And that creates a membrane. So we're going to go through this. This is just a quick introduction because hopefully you can integrate this into your office, but you're going to have to do some research. Go onto YouTube, study some journals, but there's a lot of information. I get the patient in, I get them numb first in the mouth, then I draw their blood, 4 vials. And then you spin it. When you spin it in the centrifuge, you want it to be balanced, okay? You need them opposite of each other because it's going to spin, and if it's not balanced, that machine's going to just vibrate and create all sorts of noise, and then it won't separate the blood, okay? So make sure they're balanced. And when you take 2 out, you take the 2 that are balancing each other out. You take the 2 out and leave the other 2. Oh boy. Sorry. Okay. This is all I use. I have a syringe, an instrument that's going to compact it. Now, look, this is what we pull out. After you spin it, full disclosure, my assistant put it in for 4 minutes, and it was supposed to be in for 3 minutes. So we spun it 1 minute too long. And what that did is it caused it to coagulate or combine into a big, like, sponge that's connected. If you do it for 3 minutes, then it's going to be separated but liquid. Then you take a syringe and you suck it out and mix it with your bone and let it sit, and then it coagulates and creates bone that's like putty, and you can compress it and put it into shapes and stick it in the socket. Well, because this went 1 minute too long, it wasn't liquid, it was coagulated, but that's okay. We still put it in there, we compressed it, it still has what it needs. So right now I'm putting it in to the bone. Right there, boom, look at that. We mix it with the bone graft. Okay. So then I take that, I put it in the extraction site, number 19. And then while I'm doing this, my other 2 vials of blood are spinning for 5 to 10 minutes to create a membrane. And you'll see that here next. My assistant does all that. I don't do it. I try to get it in so it goes all the way to the bottom of the extraction site, all the way to the apex. I have very little complications with healing. Okay, here comes the membrane. Looks like a sponge. Right there. Okay, so I loosened up the gums on the cheek and tongue side, and I'm going to tuck it under the gums so that the gums are holding it there. And so half of the membrane is on top of the bone and half is under the gums. Okay, I do that on the lingual and the buccal. And then I suture everything together. And I say, come see me in 1 week, and I'll take out your stitches and collect any unpaid balance on your bill. But we try to collect at time of service. So suture it. And we are done. I'll take a final x-ray. And so just to confirm, there's the x-ray right there. Nice bone graft, okay? You can also do a paper membrane or a dissolvable membrane. And that's, you know, what people do if they're missing like a lot of bone on the buckle or the, you know, a wall, a bone is missing. You want to use something over the top of that. But that's something that an oral surgeon might talk to you about next. But anyways, thank you very much. I hope I didn't bore you to tears and that it was educational. Also, if you have any questions, you can WhatsApp me. And then if you want any consultation on your dental office, what you could do differently, I'm willing to help you go over some ideas so you can be more efficient in your office. So thank you.
Voilà, on applaudit pour le présentateur mais il n'a pas respecté le temps qui était imparti, mais c'était aussi intéressant. C'était intéressant. Il y en a qui n'ont pas regardé, docteur. Il y en a qui n'ont pas regardé, qui ont eu peur. Il y en a qui n'ont pas regardé, qui ont eu peur. Nous allons continuer les présentations. Nous allons enchaîner, comme on l'a dit. Il faut garder les questions, il faut noter les questions ou les observations ou les commentaires. Sinon, en tant que médecin, j'ai vu que c'est intéressant. Il a beaucoup d'instruments. Et dans nos petites formations sanitaires, la plupart des fois, on a 1, 2 ou 3 instruments seulement. Si on échoue pour un instrument, on n'a pas d'alternative des fois. C'est le souci que j'ai vu qu'on a. Et voilà, nous allons continuer avec une autre présentation sur la technologie géomère en dentisterie esthétique. Nous avons un chirurgien dentiste en dentisterie esthétique et restauratrice qui va nous faire cette présentation. Il est, comme vous l'avez entendu, chirurgien dentiste spécialisé en dentisterie esthétique et restauratrice qui exerce à Nairobi, au Kenya, titulaire d'un Bachelor of Dental Surgery de l'Université de Nairobi, diplôme de 3e cycle en dentisterie restauratrice et esthétique obtenu au Royaume-Uni, et il poursuit actuellement ses études en master oui, je m'excuse, titulaire d'un diplôme en médecine esthétique délivré par l'American Board of Aesthetic Medicine. Son expertise porte principalement sur l'esthétique dentaire et la dentisterie biomimétique, et l'esthétique faciale et la pratique fondée sur les données probantes. Privilégie les techniques mini-invasives visant à obtenir des résultats fonctionnels, esthétiques et durables. Elle est clinicienne certifiée. Vous allez m'excuser, je ne suis pas bon en anglais. Invisalign et K-Option Reader de Shofu. Se distingue également dans le domaine de la formation clinique et l'engagement professionnel. Elle est donc la conférencière qui est invitée autour de dans notre congrès scientifique Dentaire. Elle s'appelle Henal Patel. Elle est la bienvenue pour nous présenter cette technologie géomère que nous allons découvrir nous aussi. Merci. Je pense qu'elle peut faire 30 minutes et peut-être pas 1 heure de temps. 30 minutes, ça peut aller?
I think because we're just going to allow her to present everything she has for us because it's not her that delayed the program, but you know we want to hear everything. I think we will give her as much as time she can. Okay.
Thank you.
You've been sitting here talking about teeth for so long. So, since I'm here in Bujumbura, Burundi for the first time, I want to bring something from back home here. Back home in Kenya, what we love to do, we all love to dance. We like to get the blood flowing. So, I want you to all get up, maybe for just 30 seconds, just so we can get the blood flowing and you're all ready to listen about teeth a bit more, okay? Dr. Cynthia here has offered me a lovely song that we can probably move to a little bit. All right? Do you have any great dancers who wants to lead the group? No? All right. Got a good choice? Yeah, move. Get your blood flowing. Yeah. I forward Lovely, lovely, lovely. Thank you. So I see it's not just a Kenyan thing. It's probably an African thing, isn't it? Great. Now that we're a bit happier, we've moved a bit, blood's flowing, let's talk about teeth a bit more, okay? Firstly, before I say anything, thank you so much for having me here, Dr. Cynthia, and the rest of the organizing committee. Congratulations on your very first dental conference. As we know, the firsts of everything are extremely special, and I am extremely excited to be here to share this first with you guys. More than that, I'm actually excited to talk to you about something that's very close to me clinically, aesthetic and restorative dentistry, okay? So before I start, I just want to know who I'm talking to. So by a show of hands, how many dentists do we have in the room? Many? Okay. How many are interested in aesthetics and restorative dentistry? Okay. And now from those of you, how many of you have started a composite restoration and along the way you start to pray and hope it looks good? Yeah, even I've been there. All of us, right? So I think I'm talking to the right crowd. Aesthetic dentistry is fun. It's exciting. We all love the transformations. We love the after photos. We love when the patient picks up the mirror and smiles and goes like, oh, I love my teeth. But what the patient sees at that point is the final product. Yeah? What we as clinicians see every single step that had to go right for us to reach that level. Yeah? We have to look at the tooth preparation, the isolation, the bonding protocol, the shade selection, layering technique, finishing, polishing, occlusion, patient acceptance. There is so much that has to go right for the patient to see what they see in the mirror. Right? And all those factors made me think, there's so many restorative materials in the market out there, which one is right? Because they all promise beautiful results. So why why should I pick one material over the other? Or is there a product in the market that can provide more than aesthetics, more than strength? And that is what led me to the JAMA technology. Okay, so before we go any further, I am going to, sorry, I don't want to be rude. I forgot my clicker, so I'll be using my phone as a clicker. Let me just set it up. Great. All right, so my name is Dr. Henal Patel, and I'm an aesthetic and restorative dentist based in Nairobi. I did my undergraduate from Nairobi University. I graduated fairly recently in 2019, after which I went ahead and got my postgraduate diploma in aesthetic and restorative dentistry through British Academy of Restorative Dentistry. I also hold a diploma in facial aesthetics. My everyday is based a lot on general dentistry as well as the specialized dentistry that I do. Is this what you encounter in your practice? Yeah, for me, this is what my day-to-day looks like. Patients with fluorosis, patients with stained composites, dental caries, chipped teeth, and it's different patients, different cases, different complexities. They all don't have one way of managing, right? Now, because I used to see these every day, most of the time patients walk in looking like this. Right? What's your fluorosis burden in Burundi? Is it similar to the rest of East Africa? Less? More? Less? Okay. So for us in East Africa, I recently visited Uganda and Tanzania, and they told me their burden is as severe as we have in Kenya. Back in Kenya, we used to have fluorosis just within the outskirts of Nairobi because of the Rift Valley, but over the past few years, because of the increase in population and demand for buildings and water, there are lots of boreholes that have been brought up. So now our demand for fluorosis is extremely high. So yeah, most of the time we get patients walking in looking like this. So as clinicians, when we look at this, there's a lot we can see. But the first things that pop out are there's generalized fluorosis, yes. Bleeding gums, so there's inflamed gums. There's a lot of plaque retention. There's dental caries. Then if you go and nitpick, you can see the rotations, you can see multiple color transitions, but that's not what I want you to look at. I want to look at what we see basic, right? Now when I'm looking at this, do I want a restorative material that's just going to plaster the tooth surface? Do I want a material that will plaster and make it look good? Or do I want a material that may be able to protect the tooth underneath? Right? All those things made me ask myself a question. What do I really want from a restorative material? Aesthetics? Yes, definitely. I want a material that will look good, right? Predictability? Definitely. I want to use a material, be happy with it on Monday, and on Thursday when I use it again, it should behave the same way it did on Monday, right? I want a material that is conservative in the sense that my approach is very minimally invasive. So will this restoration be able to be in a cavity that is minimally invasively prepped or not? And the last part is added functional benefit. I might sound a bit greedy when I say this, but I sort of created a wish list, if you put it. I wanted a material that had aesthetics, a material that had strength, which all of them did. Then we went ahead and said, what if the material could have some bioactive property? What if it could protect the tooth it's placed under? And that's why I added the last part, added functional benefit. Now I want to ask you all a question. Does material choice really matter in aesthetic dentistry? Yeah? Good. So how I like to put it I like to put it in 3 dimensions. You have the very first one, which is the clinical dimension. Then you have the biological dimension, and one which I feel like is slightly neglected is the practitioner satisfaction dimension. Okay, so let's walk through all the dimensions. The clinical dimension is, will this material provide me the aesthetics? Will it provide me the strength? Will it provide me the longevity I need it to do? Okay? The next part is the biological dimension. Will it be conservative? Will it work in a minimally invasive prepped cavity? And does it have any bioactive potential? The last one, the practitioner satisfaction dimension. It's easy to sculpt, easy to mold. So these three dimensions, for me, feel like it's very important when it comes to you, when you're choosing what material you're going to use in your practice. So now that's a lot, right? You want a material that has good clinical performance, it's bioactive, and ease of handling. Are there any materials that can provide everything? We're all dreamers. It's good to have a wish list, right? But we need to be realistic. Is it possible? Well, we shall see. Let's look at how materials evolved. This is not the chronological evolution of materials, obviously, because we do know composites were already in production when glass ionomers came into the market. But I like to place it this way because I like to start with glass ionomers. When glass ionomers were required, then they put resin in it. Yay, strength. Aesthetics? Not really. Then came the composite resins. They have Gymer technology. Gymer technology is something that's patented and manufactured by Shofu, and it has been incorporated into most or almost all of their products, okay? So let's look into what it is. Gymers are hybrid materials, okay? So they combine the bioactivity of glass ionomers with the strength, aesthetics, and handling properties of the composites. They put them together, and that's where we get a material that is bioactive, as well as strong enough, aesthetic enough, and easy to handle. The core of it, yeah, it's just a lot of science, but just stay with me. This is where things get interesting. How is this created? Oops, sorry. Yeah. How is this created? So they take the glass particle, and in anybody who's interested in science, it's the fluoroborosilicate glass particle that is pre-reacted with polyacrylic acid. Okay? This reaction is confined to the surface. Now we have a surface that has been reacted with polyacrylic acid, and then that forms a stable glass ionomer phase around the glass core. This is then ground up into different filler sizes, and then is the multifunctional glass core. I like to think of it as the reservoir of where all the ions are held. Okay? Then the outer layer is the glass ionomer phase. This has been shown to be released by the SPRG particle. You have fluoride, strontium, sodium, borate, aluminum, and silicate. And we will look into these now. There's a short video. I don't know if it's going to play and you'll be able to hear it, but let's give it a try. Alright, so that was just a summary of what I've said so far. Now let's look at what these ions actually do. Okay, so the SPRG filler does fluoride release and recharge. And what do I mean? When the intraoral ion concentration is low, fluoride moves from the particle into the oral environment. Okay, and now when the intraoral ion concentration is high because of varnish, toothpastes, the gymer now absorbs that fluoride, technically replenishing what it had released. So this is not a one-time release, it's a continuous release and recharge process that takes place. Yeah, so this is basically just showing you how the release and recharge of the ions occurs reversibly. This RG filler particle has been incorporated. Within minutes, the pH rises almost up to neutral. Okay? And then the rest is just showing you how the ion release, the bars at the bottom, are all the amount of ions being released increases with time. This is a very interesting study. So this is showing inhibition of plaque formation. This study was done in Asahi University, where they made buttons out of the SPRG containing composite and a conventional composite, and then they bonded it to the molar buccal surfaces of the molars. And then they examined it under a scanning electron microscope to see how much plaque formed in all, right? And it's quite evident that the SPRG filler particle had relatively less plaque formation. It's not no, it's less plaque formation than a full-grown plaque formation on the conventional restorative material. So just going to look at another short video explaining this. Okay, so let's put it all together. We've seen what bioactive properties the Gyma technology has, right? There was the fluoride release, the fluoride recharge, acid neutralization, and less plaque accumulation, right? Why are these important for us? You need to remember the restoration that we're putting inside an oral cavity. We're putting in an area where there's constant acid attack, there's constant colonization by bacteria. So this restoration has a margin that's constantly exposed to this. So with the possibility of all this, you're protecting your margin because you're reducing the rate of demineralization and increasing remineralization that's occurring at that margin area. On the SPRG filler technology, the QR code is right there, and there's another one right there. Just one more slide. I do not want to talk about all the ions and what they do, but this is basically just a short summary of what research has shown that they're capable of doing. All right, a lot of science. Now we're done. Now we can get into the fun part, okay? Let's look at some clinical cases. I want to show you how this technology and these products have become part of my everyday practice, why I've started using them, and I'll share a few, we'll go through a few workflows as well, so I can give you an idea if you have a class 4, how to build it up, if you have a fluorosis patient, what you can do. And then if you have any questions, you can let me know. I think over the course of today and tomorrow, we might do some live demonstrations for you as well to show you how the material works and how to do a class 4 and a class 2 cavity as well, okay? So we're gonna start off with a class 4, okay? So we're going to start off with a workflow. So that's a class 4 restoration, okay? I want to walk you through how you can achieve this. And before I move forward, I really want to emphasize on one point. Please, please, please have a workflow, okay? If you have a workflow, you'll always get predictable results, because you'll always know what your next step and next step and next step is. If you don't have a workflow, you're going to be rushing and you'll be jumbling around during your procedure. Your nurse will be running around looking for things you didn't ask for before because you didn't have a workflow. And we all know those interruptions just throw you off. Well, they throw me off completely. If my nurse has to leave the station to go look for things like 10 times, I have lost my train of thought. So always have a workflow and you'll always get predictable results, okay? So let's look at this. This is how the patient had walked in. They had a failed composite restoration and secondary caries, okay? So I like to start with the shade match first, because if I take you back to the previous photograph, you'd be able to take a photograph and then have a look. You could also put a strip if you want, because there's always color variation from the cervical to the incisal edge. It's your preference, you do what you want, but shade match first is extremely, extremely important, okay? Then we start prepping the tooth. So I've excavated the caries, I have smoothened the sharp edges, I've done a bevel. I don't know if you can appreciate where the bevel ends. Sorry, I don't have my clicker, so you'll just have that there. Can you appreciate that? That's a minimal bevel I've done. You could do an infinity bevel. Infinity bevel covers the entire surface of the tooth to giving you a better blend. But because I like to be minimally invasive, I think this works better in such cases, okay? Then selective edge. Please, please, please. Always selective edge. Do not total edge. Etch your of mine for at least 20 seconds. And then I gently air dry and then we cure, okay? Then the next thing I like to do is I build the palatal wall and the mesial wall. And I know it says INC and A2 and all that probably sounds really foreign to you right now. So I'm going to ignore the shades, but they're just different shades, okay? I need you to understand that enamel and dentine are two different substrates. They have different optical properties, okay? So you cannot use the same shade to replace enamel, and you cannot use the same shade to replace dentine. We must respect the part of the tooth we're replacing with an appropriate material, okay? So in this case, INC is an incisal shade, it's a translucent shade, and that's what I've used to build the palatal wall, and A2 is a body shade, and that's what I've used to build, again, the enamel wall part of the tooth. The next part, you'll see I have used a material called A2O. The O basically stands for opaque, and that's my dentine shade, okay? I have had a lot of young clinicians back home ask me that their class 3s or class 4s are looking see-through. I don't know if you have problems where you do those restorations and they look see-through, yeah? And the reason they look see-through is because you don't have a dentine opaque layer in the middle to block out the light. So you should always have a dentine layer, and in this case we have used O2, and then I do my final layer with A2, which is the body shade. You finish and polish, okay? Finishing and polishing is not a 2-minute procedure. For me, as long as I take to build up the tooth, I will take equally as long to finish and polish. It's extremely important you take your time when it comes to finishing and polishing, because this is what will ensure your restoration lasts a long time. It does not stain, and there's minimal micro leakage as well occurring because there's no areas getting stuck for bacteria to hang on to, okay? So I'll walk you through my finishing and polishing protocol. It's a 4-step procedure. So I like to start off with this. Jour white stone, it's basically just a white stone. You know the high-speed white stones that we use? I use this for gross reductions. If I ever have any excess bulky areas, I will start off with this and then remove that. Then I move on to this, and this is my absolute favorite rainbow polishing kit in the market. Okay, and I'll tell you why. All rainbow polishing kits, if you've seen them, they have a metal that protrudes from the middle. Yeah? So when you're polishing, that metal will scrape and touch and scratch your composite. This, the metal does not protrude outside. As you can see from that purple one, there's no metal protruding outside. So I'm comfortable enough to even do this. And I know it's not going to scratch my surface, okay? So this ranges from coarse to fine, from black, purple, green, and pink. You cannot skip one and go straight to the last. If you want the luster and shine, you're using it to finish. So it will cut, okay? And light pressure is now when it will do the polishing. So I have an unusual way of using these. I start off with the black, move to the purple, and then come to one gloss, and then get my shine with the green and pink. Okay, I know it sounds a lot, but once you start doing it, it just flows. And then the last thing is I like to use this. It's a Super Buff mini disc. It's a diamond impregnated disc, the direct dia paste. It has diamond particles in it, so this is my last step in polishing, and now this is what gives that light reflecting shine back from the restoration. Okay? Good. Now this is the next one. Again, I just want to show you how a consistent workflow will always give you predictable results, okay? So it's again the same steps: selective edge, prime, bond, build a palatal shell with an incisal enamel shade. Then you build the wall and the dentine layer, and that's your final outcome. Okay? So same protocol, same workflow. I know I'm going to get predictable results. Just one more on this. The reason I put this on is because I want to show you this. Build your palatal, it's basically a sexual band. You can use it to build your mesial wall the way I've placed it. And the good thing is it has that curvature. And the same material, if you invert it, you can place it palatally to build a palatal shell. I'll show you later on. Okay, and that's the finished and polished product. Looks a bit blurry here. Yeah. Okay, now let's look at veneers for fluorosis, composite veneers for fluorosis. I know your burden is not as much, but we'll just give you an idea of different layering techniques you can use for when you have teeth that are heavily stained as well. Okay, so this is a patient who has generalized moderate fluorosis. He has older masking that was done. As you can see, the masking was done at a very young age, and that's why there's a separation between the composite margin and the rest of the tooth. There are white opacities, there's brown stains, there's pitting as well. So we isolate first, and then we prep the teeth. In this case, you're most likely just removing the old composite and placing a margin. Etch, prime, bond. And then, now here we use this thing called A2O. A2O, as I told you earlier, is a dentine shade. Okay, so I use it as an opaquer to be able to block out the brownness from the fluorosis. This also helps me do some IDS. IDS stands for immediate dentine sealing. This helps reduce post-op sensitivity because in this case you can see there's quite a bit of dentine exposure. This is what I was saying with the shovel matrix. You can see how I've inverted it and placed it to build a palatal shell. And that's what the palatal shell looks like. So if you're doing freehand build-ups of palatal walls, it's a great thing to have in your drawer. So that's your palatal shell. The other thing about palatal shells are they have to be thin. So you're looking at about 0.5 mm, not too thick, because if it's too thick, it's going to take away your space for dentine. Okay? And that's your final product for composites. So I've used dentine shade A2O, and then we finished with a shade called BW, which is bleach white. For a lot of fluorosis patients, you won't be able to use your regular A1s because they will find it yellow because they're used to whiter opacities on their teeth. Okay? So that's the before and the after side by side. Okay. So that was polychromatic layering. I'll show you a few more cases where we've done polychromatic layering. That basically just means we've used different shades, laid them on top of each other. So this is another one where we used A2O and BW. A2O, the dentine shade, used as an opaquer, and then our body shade at the top. I also want to show you a case of monochromatic layering of composites, composite veneers for fluorosis. It's just to show you sometimes you don't need everything to work. You could have one shade and it's still possible for it to mask out the opacities. So this, she's a very young girl, and she lost her 2-1 in a car accident where it just avulsed, which I'm learning is a very common injury for children. Is that common here as well? Yeah? So if you look at this, we can see obviously the generalized fluorosis first. She has white stains, brown stains, there's some diastemas, there's a midline shift, there's a missing tooth. Now, what do we do, right? Ideally, the best option for replacement, as I always say, the gold standard for replacing a missing tooth is an implant, okay? She's a teenager. You can't place an implant right now. So, this is what we went for. So we have masked the teeth with one shade of composite, and we've put a Maryland bridge for her. So the Maryland bridge is on the 2-1. So we can see with this, we've been able to mask the discolorations. We can't see. So she went for an A1. She didn't want super white teeth. So if you can see the difference between this and the first case I showed you, that was a lot whiter. For fluorosis or for any cases, when you're doing multiple teeth, it's always important for you, yes, to select the shade, but for the patient to select the shade as well. Okay? So she went for an A1 shade, and that's what we have. We've managed to close the diastemas. We've managed to block out the opacities. The midlines are still not coinciding completely, but it's the closest we can do without moving the teeth. Yeah? So that's the before and the after. And once she's ready for implants, we're going to remove the Maryland bridge, and she'll have an implant placed there. Okay. Now let's look at spot bonding. There are lots of this is another fluorosis case as well, where the patient has just a certain area that's bothering them, okay? And in this case, I've used a white stain. So, this case, you can see the patient has lots of white opacities on her teeth, right? But the only thing that was troubling her was her canine. For me to get that white in the clinic, it's not possible. I can match multiple composites from several companies, but it's going to not match that white. So what we did was we used a white stain. We used a white stain underneath and layered it with BW to get something close enough, okay? And then again, same patient on the other side. Only concern was the distal surface of the 2-1 and the canine. And that's what we did. And these are really fun to do because it's quick. You're not really prepping much, just putting a slight bevel. But obviously, when you're dealing with these cases, managing patient expectations is very important. They need to understand that composite veneers are not the same as porcelain veneers. They don't cost the same, so they definitely will not even look the same, and they may not even last the same duration, okay? But most of the patients I do this for are young teenagers who we can't do definitive long-term treatments for yet, okay? Now let's look at a few cases of diastema closure. This was a patient, mid-Invisalign treatment, she decided she doesn't want to continue anymore, but she wants to close her gap. So we went in and closed it using 3 different shades. You're probably wondering, hey, you left a black triangle, right? But that fills up. Within about 2 weeks, the gum will grow into that space. So the importance of, like, if you can look at the lower teeth, because we've used the 3 shades, we've been able to block out and it's not see-through. It blends into the tooth nicely. This is another case of diastema closure. This was post-ortho, and they just couldn't manage to close that tiny gap, and that's what we did, okay? Again, monochromatic layering. We used 3 different shades and blended it in to make it look uniform and nice. This is the same patient, but it's a frontal view. It's injectable composite, okay? It's not marketed, and it doesn't behave the same as a flowable. It's an injectable composite, and I'll tell you why. First, in this case, we only used this alone. We didn't use any dentine shade to close up the space because you can see the diastema is not as big. For me to layer different shades, I would have to create more space. So we used just the injectable, and we were able to close the gap nicely. Okay, so these are injectable composites. It's called Flow Plus X. They come in 2 different viscosities. There's F00 and F03. And what does that mean? F00, if I put it, it's not moving. It will stay, it will not flow. So if you want the one that flows, it has a low flow. It's really good for your class 2s, class 1s, where you want to use it as a liner for the base. It will flow very nicely and seal everything, okay? This is a very beautiful photo that was taken by a really great clinician. She's called Dr. Dina Ez. She's an associate professor at Cairo University. This is with Flow Plus X F00. You can see how she's putting it, but it's actually not moving. It stays in that position. And that allows you time for tricky situations where you want to put a composite and allow time for you to move out and for a nurse to come in to cure. Okay? Now let's look at some class 5s. This patient had failing class 5 restorations. As you can see, there's a lot going on. There's a lot of staining, there's perio, there's old worn out composites and stuff. Patient was in a rush, so he was referred to me by one of our own doctors in the clinic saying he wants to replace the lower composites. So we went in and replaced it for him, okay? But in this case, you can already see the patient doesn't have the best oral hygiene. So if you're able to use a material that may protect the tooth, it's a good position to pick one with bioactive properties in such a case because you don't want the secondary decay or poor marginal integrities. So let's look at a class 3. Again, this was just put in just to show you that you can avoid getting the see-through composites by layering different shades on them. And she went through most of her life like this. I think she had chipped her tooth, and the dentist she went to when she was young just filed her teeth down to, and she thought this was normal. So when she finished Invisalign, We were like, hey, we can fix that for you. Please let us. And I was glad she let us. Yeah. Now, obviously you're thinking, but how strong is that? Right? Like, can she bite into maize? Can she tear sugarcane? No, she can't. There's no way she can. Even if you put a veneer on this case, she would not be able to bite into sugarcane or maize on the cob or anything. But yeah, again, now in this, same shades, same technique, same protocol. Okay, and then this is a case of edge bonding. The only reason this is here is because now this was done with a single shade. It's because of a habit. So if I put this and let her walk out of my clinic, she's gonna chip them instantly. So for this, you have to make sure the habit is controlled. And the way we control this habit in our practice is, 1, she'll get night guard. 2, we give her some masseter Botox to help the force which is clenching and grinding. And so we recommended an extraction followed by an implant, but he's originally from Europe and he was not going to go to Europe until the summer. So it's like, please, can you do something that I can keep the tooth until I get back home to have it sorted out? So we did a core build-up. And this is where I was telling you the F00 is really great for core build-up, for DMEs, because if we go back, you can see the mesial margin is way below the gum, right? And because we need to bring it up, I'm going to use my beloved shovel matrix and hold it in there, and I'm going to use my F00 to raise the margin up to above the gum level, okay? So we have raised it, we've built the core, we've prepped the tooth, and then we've designed, so we had to temporize. I can't let him go home like that, right? So we had to temporize. So we did some designing for a temporary crown. We printed it in the clinic and gave him a temporary 3D printed crown the same day. Okay? And that's the temporary crown in place. He went, he came back, and that's the final restoration. Which, this might buy him a few more years before he actually needs an implant. I want to discuss one more thing, which is your veneer cement. Shofu has this kit called Beauty Sem Veneer Cement. It's a fantastic veneer cement kit. It comes with 3 shades. It has the M value, H value, try-in paste, which is very easy to clean out after you've done your try-in. Okay? So this is a case where we used it, and these are porcelain veneers that were done on her. Great. Thank you so much. Merci beaucoup. I lied that this is the only French I know. Okay, thank you. Sorry, also if you have any questions, I'll be here for the next 2 days, so you can always feel free to come find me and ask me whatever you may.
Nous applaudissons à l'orateur qui vient de nous présenter sur la technologie géomère. Elle méritera quand même des applaudissements. Vous allez garder les observations et les questions qui seront posées après, je crois, la pause déjeuner. Pour le moment, nous allons suivre notre présentation sur la planification du traitement en orthodontie et utilisation des mini implants orthodontiques qui sera présentée par Dr Mohamed Ahmed El Hachid. Alors, qui est Dr El Hachid? Le docteur El Hachid est spécialiste en chirurgie orale et maxillofaciale. Il est propriétaire de Pioneer Dentaire Care à Alexandrie, en Égypte, depuis 2009. Il a obtenu son diplôme de Bachelor of Dental Surgery à l'Université d'Alexandrie en 2007. puis son master of dental surgery en chirurgie orale et maxillofaciale à l'université d'Iker en 2024. Depuis 2023, il est également propriétaire de Egypt Med Ltd à Kigali, au Rwanda. Le docteur El Rachid exerce actuellement comme chirurgien oral et maxillofacial à Penn Dentaire Surgery à Kampala, en Ouganda. Fort de plusieurs années d'expérience dans le domaine de la chirurgie dentaire maxillofaciale, il s'intéresse particulièrement à la prise en charge spécialisée des pathologies et affections de la région orale et maxillofaciale. Nous donnons la bienvenue au Dr Ahmed Al-Shidri pour sa présentation.
Good afternoon for everybody. This is really my pleasure to be here in Burundi for the first time. Despite I heard a lot about one of the innovators of dentistry here, I didn't meet him until the meanwhile, despite he's from my same home city. I think everybody of you knows Dr. Amin. Yes. So this is so much inspiring because everywhere when I go here, do you know Dr. Amin? Do you know Dr. Amin? Guys, I don't know him, but this is very, very blessing because he's not, I have never met him, but his reputation is walking around every one of us. So it's my pleasure, and we promise a lot of collaboration between us from Alexandria or Cairo or whatever, Egypt in general, and the Burundian dental community here. Okay? Actually, there is some undergoes sleeping. Okay, actually there is a interpretation about the topic of this lecture. As an oral surgeon, we will be much more focusing about to replace missing teeth. This has become very trendy and very important, and actually a work that each dentist at least should do the basic treatments. Okay, because for example, if you have a patient walking into your clinic with a missing molar, for example, you would ask him to go for a bridge. Is this the best treatment option? You have to grind the neighboring teeth, okay, and you have to provide him a bridge. He solved one part of the problem. But after some years, for example, he will be getting bone resorption below the pontic and maybe even more failure to the abutment themselves. Open your minds. There is a lot of treatments that can be done, and you can apply it in your clinic or refer it, or you assist in it in one of different ways. Okay? So we have to take, for example, if we have an implant placed like this one, you have to go for implant placement. After that, putting healing caps or healing abutment for some time. And after that, you have to expose your implant. After that, you need to take an impression, acquire a master cast, do, try in, and after that, go for the final prosthesis. Okay? Nowadays, what we are going to be doing, for example here, this is all the steps again. And after that, you have gotten your impression. You have to undergo for model, okay, wax pattern fabrication, sprueing, investing, casting, decasting, finishing, and after that, delivery. All of us know dental material does have some dimensional changes. Not only single material having 0 dimensional changes. So, if you are counting all of these steps and you having an error margin of let's say 1%, okay, or even let's make it in numbers. If you have an error margin of like 25 to 30 millimeters, multiplied by 10 steps, so you will end up having a very big error margin here. You see here, this is 200 up to 240 microns, which is equal like 1/4 of a millimeter. This is catastrophic in dentistry, unfortunately, because we are dealing in microns. Okay, so here comes the digital workflow. As you see here, when the patient walk into your clinic, asking you, doctor, please, I need to have one or 2 implants or whatever. What's the first step you have to do? After clinical examination and everything, then you have to take him to the CBCT scan. Okay, I know in Burundi here we still don't have CBCT scanners, but we can manage it with the available facilities here who have conventional CT. With some manipulation of the data, you can get a nice image and you can customize it for your patient treatment. Okay, and after that, if you are not having an intraoral scanner, you can take a physical impression, send it to a laboratory. Please, can you scan these models for me? After getting both, you are able to combine them to get a surgical guide for a patient, which will help you perfectly to place your implant. As you see here, this is the surgical guide. It will direct you where you exactly putting your implant, which help you in the future to have a desirable prosthesis. Okay? Why we are saying putting an implant that helps you apart from touching the root, for example, how will you be managing a common path of insertion for them? So we have to change our way in thinking before placing implants. I should put my implants in a position that will help me to provide an acceptable path of insertion. Okay? Not put an implant wherever bone is available. No, this is the old way of thinking. We are thinking now crown down. So I have to think about the prosthesis first, and after that, put the implants. What if I'm not having bone? I can create bone. Either I do grafting, I do graftless solution, or do whatever solution. Okay? So let's go for the clinical cases next. For example, a patient walk into the clinic here. He's actually having mixed treatment. As you see here, he has one of the failed implants we have decided. As you see here, this is a CBCT scan. This is the basic CT scan. And in this portion here, this is the STL or the model for the patient. We combine them together in order to have a virtual patient. So the patient have left your clinic, but you still have him in between your hands. Okay? You have his CBCT scanner, so meaning you have his bone. You have STLs, so you have his soft tissue. What else you need? In this case here, we have even done a pre-extraction wax-up. Meaning what? I have designed him like a wax-up or a future prosthesis, which will help me to visualize the relation between the created wax-up and the placed implants. Okay? Even more here, When we are talking, when what you see here is a surgical guide. What's the purpose of this surgical guide? We will see it to retain this metallic framework in place for the whole throughout the surgery. Okay. And this is the implant placement guide. Actually, in this case, we have 2 layers of guides. Imagine you are building a house. What's the first step you are going to achieve? Excavate. What's the reason for excavation? Not only providing enough material for foundation, no, to level up the soil, to have a uniform platform so you can lay out your foundation. So in this slide here, as you see here, I have to trim all the bone at this level, okay, because we have extracted everything. So after modifying the bone to be uniformly around the whole jaw, you attach your layer of this surgical guide. As you see here, for each implant here, we are planning to have 6 implants. The 6 implants here, each of these cylinders will be exact position of the future implant. You are going to drill through it. So there is no chance for you to mistake and over drill. As long as you are following the plan, you are using, for example, L13 drill, you can't go beyond it. So no compromising for the vital structures, because we all know here in this in the lower arch we have what? The inferior alveolar nerve. So you are not able to touch it. Okay? Another very important thing, when you, as you see here, can you tell all of these sleeves, are they parallel or not? For the guide, for the implant placement layer. And you see here, this is after reflection of the flap, plateauing of the bone, and the 6 implants are already in place. Okay? That's it. That's the goal you need to achieve. As you see here, all of them are more or less parallel. And in implantology, we have like, if we have like 10 degrees or less divergence between implants, it's possible to have the prosthesis ready for them. You will not be having any problem when you are doing your final prosthesis, regardless, is it the same result as this one. Actually, this patient has walked into the clinic without anything, and after 3 hours, he has left the clinic with this appearance. Even when we finished delivering his prosthesis, no, it's not my teeth, it's not me. Okay? So the patient can walk in without any teeth, without anything, and after that, sometimes in the clinic, he will be leaving with a nice temporary like this one. Okay? And as you see here, this is the post-operative OPG. All of them are more or less parallel. Actually, for the upper arch, he has some implants. We decided to retain some, and we decided to remove some of them. Okay, so this one newly placed, this one newly placed, this one is newly placed, this one is supposed to be removed. Okay, as you see, in one session. Okay, another alternative for the treatment is custom-made implants. Do you know how much is the prevalence for amyloblastoma cases in Africa in general, among African race? Actually, it's the highest. It's the highest. We see it very, very, very popular, especially in. But we have to give the patient another chance. He wants to live. He wants to talk. As you see here in the next case, you see here the bone. On all of them, this is the typical knife edge ridge. We call it in the textbooks knife edge ridge. It was 2.3 millimeters. So we can think about grafting. Grafting for this area, we have to combine autogenous and allograft material or xenograft material. autogenous. We have to think about autogenous first. How can we get autogenous? We have to open a donor site, mobilize the graft, and fix it in the place, and ask the patient, please, you can wait for 9 months, up to 12 months, to get the implants placed, and after that, you will have the iliac crest to mobilize some of the bone and put it in his jaw. Sorry, doctor, I will live like this. I no more need your treatment. So, we have to modify. What we are going to do in the next, as you see here, this is the treatment options. Let's go for the last of them to see. The exact same workflow. CT, CBCT, STLs, designing, and manufacturing. And now, actually, the solutions have evolved dramatically, because for 3D printers, all of us has heard about 3D printers. They are no longer printing resins only. No, even for metals, it can be 3D printed. So this has revolutionized the treatment options for the patients in a very extreme way. Let's see how. Hopefully it works. As you see here, this is the actual mandible of the patient with the real-time measurements, and this is his dentition. So we are custom making a framework that will be setting on the bone, not inside the bone. In these holes, of course, you know the screws for maxillofacial surgery. We just use them to be holding the framework in place. And even more, can we make a guide for this one? Let us have a look. You see, even the future teeth are set up, and to visualize even the future prosthesis, how will it be looking like? Because I no longer need to have cylinder-like implants. No, I want a plate implant. So through these boxes, I will be cutting precisely. So I have a housing that will include my implant. And after that, we will be securing the framework using our CMF screws. This is what? This is the surgical guide in place. As you see here, we have planed all the bone around the boxes here. So I am very sure that my implant will be resting in an accurate position. That will. There is a very risky structure here, which is what? This is the inferior alveolar nerve. Okay. These two blades are just on top of the inferior alveolar nerve. So you don't have to worry about your available bone, your bone thickness, any of these. Okay. And this is what? This is multi-unit abutment connections. So your prosthesis will just be resting on top of them. Let's see. This is after wound closure, and this is the healing abutment for the multi-unit abutments. Okay. And this is a nice temporary, have been delivered for the patient after 6 days only. So the patient comes, leaves your clinic after 3 to 4 days with temporary prosthesis and reducing all of this time. Okay, let's go for the final one. As you see here, look, we were exposing up to this area. You see here the nice healing around the implants. Okay, and this is the posts we'll be using in the future to be carrying our final prosthesis. Our prosthesis here. This is our final prosthesis. This is not a porcelain infused to metal actually. This is hybrid zirconia titanium bar. Yeah, the metallic portion inside here is made of titanium, and the outer shell is made of zirconia. So as you see here, this is the patient after delivering the final prosthesis. In what time? 45 days. So the patient walked into your clinic without anything in this area, and he left your clinic after 1.5 months with a final prosthesis which is fully osteointegrated. There is no dehiscences, there is nothing at all. And this is the happy patient after the surgery. So as you see here, with new technologies has been introduced into dental practicing, it has been much more easier. You have a lot of facilities. Despite you don't have to acquire them locally here, by the way. By the way, in the past patient was treated in Uganda, and the final prosthesis was made in Egypt. So it's easy. We can. Thank you so much. Anyone is having questions? Definitely. Yes. No, it will be retaining the screws for the whole life of the prosthesis. Yes. Actually sometimes if a patient is traveling, okay, the issue here is how fast is the soft tissue will be healing, okay, for the bone, because this is immediately loaded. This is, you can even sometimes when we have some patients are traveling outside of the country, we scan after placing the implant, the main issue. Okay, any more? Thank you.
Bon, merci beaucoup. Et veuillez m'excuser pour ce petit temps perdu. Mais quand même, je voudrais vous appeler à applaudir l'orateur qui vient de nous présenter sa présentation. Bon, je ne suis pas dentiste, mais je me demande comment ces implants puissent tenir sur l'os pendant aussi longtemps. Peut-être qu'il va nous expliquer encore une fois. Et puis, pour le moment, nous allons suivre une présentation sur des activités de chauffe qui sera présentée par M. Abbé. Également, une présentation sur Dental Mission. Les deux présentateurs vont se présenter eux-mêmes parce que je n'ai pas les recevoir ici. Nous invitons M. Abbé à...
Amaholo. Burundi Buaku. Burundi Buhire. Shingi Ikum Mashinga. Ubgabo, le fondateur, qui a établi l'entreprise en 1922. Nous produisons des abrasifs, des fraises diamants jusqu'à 1867. Tokyo est capitale assez nouvelle. Notre technologie clé au cœur de notre savoir-faire se trouve une technologie céramique à partir de Kyoto. Nous voulons contribuer à la santé dentaire en Burundi avec vous. Ubwabo urikurira. Murakoze.
Bon, merci d'être bref et d'être concis. Ce qui veut lui poser. Avant de... Maintenant, nous allons passer à la présentation sur les complications léoco-régionales et générales des pathologies dentaires. La présentation sera faite par Dr Bisman Athanase qui va se présenter. On va prendre la pause et nous demandons à ceux qui sont chargés de la logistique de nous dire ce qui va suivre. C'est prêt? Nous allons prendre le déjeuner à l'endroit où nous avons pris le petit déjeuner. Nous disposons d'une petite heure pour retourner afin de continuer nos travaux de la journée. Et je vous souhaite bon appétit. Voilà.
Je devais exposer demain. Je vous assure que je n'ai pas encore terminé la préparation. Nibyo twari tuzi.
tugarutse nca mvuga
baca baraba uri prêt
nca mvuga kugira ngo nkoremo iby'ejo jewe ndashaka ntibiraba premo ko ari ibintu by'irigara iwanje n'irigara
je narinzi ukuri ndi programme oya ibintu bya nyuma bagitse je ndakironkea tubironkea ni bagize
de 1974. Nous avons essayé de travailler sur ce décret pour l'adapter et le rendre compatible avec la situation actuelle cette année. Et dans ce draft, il est prévu d'intégrer les dentistes et chirurgiens dentistes dans l'ordre des médecins du Burundi. Donc l'appellation va changer très bientôt et je pense que ça doit prendre la parole afin de clarifier certaines interrogations.
Ou des observations par rapport à toutes les présentations, même si on a légèrement dépassé le temps de la fin de l'atelier. On devrait terminer à 16 heures, mais comme on a eu du retard au début, nous pouvons consacrer quelques 15 minutes, 20 minutes maximum. 15 minutes, ça va peut-être aller pour les questions, pour les suggestions ou les observations, commentaires par rapport à toutes les présentations qu'on a eues. Oui, merci. La parole est à qui veut la prendre.
Bon, merci de me donner la parole. Il est prometteur. Alors je demande maintenant où est-ce qu'il il trouve la permission de guérir. Vous pouvez me rappeler le nom? Je demande si c'était 5 dents, ça allait prendre combien de temps? Merci beaucoup.
Merci. On prend une série de 5 intervenants, par exemple. C'est le premier intervenant. S'il y a d'autres qui voudraient intervenir, vous avez la parole. Oui.
Bon après-midi. Nashaka mvuge kuri ico Dr Victor ahetse kuvuga ko kidukora ku mutima. Bien sûr vyose twabikunze vy'uyu munsi. Ariko ko muri ngaha nk'abantu bashika kure bakora mu bushikiranganji kuri ico kintu kijanye na ordre des médecins, tukirindiriye igihe kinini tumva ko biri muri signature kandi ntitumenya ati bizoba officiel ryari. Twifuza nk'igisabo, twifuza yuko vuba umwaka ntuzuhere bitarashirwa mu ngiro ngo bibe officiel. Kubera iki? Hari impamvu nyinshi. Umushurgent dentiste benshi turaba general dentist, ni ukuvuga benshi ntituraba specialiste muri dentisterie. Ni ya specialisation wongereza uja kwiga kugira wongereze ube umu specialiste. Ayo specialisation rero kugira ama université akwemerere rimwe na rimwe kandi kenshi baragusaba numero ya ordre des médecins kuba uyifise nka document kugira yemezwe yuko wanditswe mu gihugu. Mu gihe dentisterie tukira aba generaliste ata maka spécialisé dushobora gukora toute dentisterie utafise kirya gipapuro. Turazi yuko kubera ihindagurika ry'abaduserukira ko vyagenda birahagarara bimwe rimwe, ariko turifuza yuko kuri uyu ahari bishikwa mu ngiro. Iyo yari recommandation kandi nibaza yuko nabo turi kumwe muri association ibaraje ishinga cyane ko biradushikira cyane gose nk'uwagiye hanze ashaka kubandanya ishuri ababloke kubera igipapuro ca ordre des médecins birababaje. Sinzi ko hari umundi afise ico yo kongera ko kuri ico mugira ico mbivuze kuko bari ngaha kugira bashika
sur la même question ou
akantu nokongera ko kw'ico kibazo kijanye na ordre de médecin nuko ico kibazo kiraturaje ishinga cane kuko kiraba intambanyi na cane cane abantu bakora mu ma institut ya leta kubera ko badashobora no kwandika imiti ku mabo ya mituweli. Je narakoze muri leta nk'imyaka 3 narinze mvayo nkibisaba ntibyigeze bikunda. Rero mw'ico gihe biratuma abandi bakora muri ico gisata bituma basubira inyuma. Twosaba ko ico kibazo vraiment cofasha kuko ni benshi no gukunda kuko urumva naho hezwa ngo yandikwe. Murakoze.
Merci.
Ubisanzwe na byinshi nza kuvuga kuko benshi babivuze. Ari abakozi ba leta ubandikiye imiti ukababwira yuko bayigura samples, ico ni kibazo kidasanzwe. Tubwe twenyene kiraduteye. Benshi baravyirutse, umuntu uze umuyobozi wacu yaravyirutse inyuma byaranse, abandi baravyiruka inyuma biranka.
D'autres observations, d'autres questions? Voilà. Est-ce qu'il y aurait un autre? Ah, okay.
Merci beaucoup. Moi, j'aimerais revenir sur l'idée à si on pourrait faire, disons, une analyse critique, parce que dans le cadre d'un congrès scientifique, que ce soit les pratiques qui sont en cours, que ce soit, disons, les nouvelles pratiques ou les... Est-ce que ce que nous avons vu, c'est bon, il y a par exemple des approches qu'on peut dire de première intention ou par exemple l'intervention. Si on doit garder quelques éléments, que ce soit pour la sensibilisation, que ce soit pour la prise en charge, que géomère ça évolue, mais je ne sais pas, est-ce qu'il y aurait-il des critiques, les études, les méta-analyses et les études qui sont en cours, quelles sont donc les données disent quoi par rapport à ces pratiques qui
Bon, merci. Il y a une question des représentants. Est-ce que cette technologie est pratiquée au Burundi? Ça existe ou c'est une nouveauté? 2. Je pose la question à Dr Patel qui a présenté ça. Est-ce que cette technologie concerne uniquement les réparations, les obturations? Qu'en est-il pour les prothèses? C'est cette technologie qui est utilisée. Merci.
Des médecins. Il y a le décret qui est en cours. Il y a la présidente de la CDU qui fait le suivi pour qu'en fait le processus soit accéléré et qu'on ait ce décret-là avant la fin de l'année, mais c'est un chirurgien dentiste qui ne signe pas sur les bords de la mutuelle et qui signe sur les ordonnanciers, et les malades qui achètent 100 pour ça, c'était pour la réparation d'une seule dent. Et qu'en est-il si le malade avait 5 dents à réparer? Ça prendrait beaucoup de temps, peut-être beaucoup de jours. C'est la question qu'il pose. Et quelqu'un d'autre aux présentations qu'on a vues peut-être n'a pas adressé spécifiquement la question à quelqu'un, mais il a dit que vous pouvez prendre la parole encore une fois.
De médecins n'abamedecin hari byinshi tutakironka kubera iyo décret iri caduque irashaje cyane. Nababwira nk'ibijyanye n'amaformation continue ubu les médecins du Burundi ntibari à jour kubera ntibafise de formation continue comme les autres. C'est pas la mauvaise volonté de l'ordre des médecins. Les révisions zabereye à une autre structure yo hejuru muri présidence uko décret yamaze gushikayo kutoso kirindiriye ko ko twofashanya au niveau du ministère kugira tuposte kugira tu tupuse dufashanye kuko twese qui est exercé par les dentistes ou chirurgiens dentistes. Nibaza ko atari ikosa ry'iwabo kuko kuvura baravyize, ahubwo amategeko niyo legisa la redogerie qui sont à jour. Rero murumva ko ari préoccupation partagée. C'est pas seulement une préoccupation des dentistes ou chirurgiens dentistes, c'est une préoccupation de tout le corps médical. J'espère qu'avec les nouvelles autorités qui sont au ministère, on va essayer d'accélérer le processus. Hari ubwo n'uwo mwaka utohera kitaraboneka kuko comme les autres kuri mutuelle de la fonction publique. Ni ukuvuga yuko turakeneye kufashanya kugira dusigure cyane kugira izi text zisubigwemo kubera nkuko nawe
Dr Cynthia asavye yuko mwofashanya pour pousser kugira ngo turabe Patel.
So you asked me how long I'll take for 5 fillings, right? If I worked at this demo pace at my clinic, my patient would probably leave me halfway through and done the shade match and stuff. After that, I'm working through each tooth systematically, so it's a lot quicker. So when I do composite veneers, it usually takes me about, if I'm doing 6 teeth, I usually do minimum 6 teeth for composites. I would take about 2 hours to do the procedure, but I usually book the patient for 3 hours. Just because photographs, explaining the procedure, shade selection, and everything takes time. Was there any other question?
Oui, il y a
26 to 30 years. From what I understand, Dr. Cynthia does have them available here. She does have the composites and stuff. She will be in a better position to advise you on what exact materials she has, but yes, they are locally available.
Vous avez parlé des processus de validation pour les appareils, pour les médicaments, tout ce qui est autorisation de mise sur le marché, etc., etc. En fait,
So, what we have been learning from you, we saw many procedures. As we are we are in this Congress, a scientific Congress, we need to have maybe a kind of a critical, analytic overview of what is done, studies. So my question was directed to each and everyone who presented there. I was intending to ask you, basing on what you've presented, what can we guard or stay with as people who work in the Ministry of Public Health? Yes, basing on what we have seen, it depends on what is maybe on the top level of impression to think about when you need to do this. So tell us what we can guard, maybe during sensitization or
de l'association afashe kwishura rapidement kugira peut-être ntidufate umwanya munini n'amasaha yagiye kuko c'est une question qui est vraiment importante par rapport à toutes les présentations. On garde
Kirundi to answer for them, so you need that one. Izante mugabo twebwe tutaratanga gukora ngaha gusunika gukreya programme canke system ishobora gusunika canke korohereza aba dentiste kugira baronse kugira bashobora gutanga izi service ku barundi unja abarundi bageronka amadolari bagenda kuyakoresha mu kindi gihugu ntaguma mu gihugu nyinshi réellement tugiye turaja mu ma conference internationale twebwe tutarashikako kandi bikwiye kudutera gukunda igihugu no gukunda ubuvuzi no gukunda akazi ukunda. Bino bintu biraryoshe kubona, kwiga no kumenya. Nibaza ko ari ico nobatekerera nk'abo muri ministère, mudushigikire mwumvize amaprojet ya.
Merci beaucoup. Je prends la parole dans peut-être pour orienter mon collègue Thierry. Bon, nous avons vu par exemple pendant la pratique chirurgicale. En plus, nous avons vu que nous sommes limités dans les lois en rapport avec l'intégration des médecins chirurgiens dentistes. Ce qui veut dire que celui qui a fait chez la dent. Donc, est-ce que il n'y a pas un niveau hiérarchisé? Donc, quand est-ce qu'on aura besoin de cette technologie le matin? Nous n'avons pas les directives nationales qui vont dire qui va.
Et merci, je vais tenter de répondre à la dernière question. Les composites, la technologie et JML. Et ça concerne les chirurgiens dentistes. Même le chirurgien dentiste généraliste. Et parce que dans ce congrès, il y a aussi, on doit aussi apprendre. D'autant plus qu'ici, nous venons, mes collègues viennent de le dire, on n'a pas de possibilité de faire la formation continue. On est bloqué par plusieurs facteurs. Le premier étant que moi j'ai eu la chance, parce que je travaillais à l'armée, et j'ai pu faire mon 3e cycle à l'université Cheikh Anta Diop de Dakar. Il y a Dr Moyoku, je ne l'ai pas vu aujourd'hui, lui il a fait la santé publique au Bénin, mais c'était financé par l'OMS. Donc des congrès pareils, c'est aussi pour apprendre, c'est la formation continue. Maintenant, s'agissant de la question de savoir si on devait utiliser ça dans les CDS, non. Dans les CDS, et là j'en reviens à ma présentation, dans les CDS, nous proposons le plateau technique OMS. C'est juste quelques instruments. Il n'y a même pas de fauteuil dentaire. Il n'y a pas de fauteuil dentaire. C'est une chaise, c'est une table, c'est un miroir dentaire, c'est une sonde pour la consultation. C'est juste pour détecter les caries. La carie, c'est une cavité, c'est un trou. Si on vous apprend à utiliser le miroir dentaire et la sonde, vous pouvez détecter. J'ai un peu oublié son nom, qu'il m'excuse, et qui voulait parler de méta-analyse et consorts. Je pense qu'on n'en est pas encore à ce niveau aujourd'hui. C'est le premier congrès qu'on vient d'organiser. On n'a pas fait vraiment des études randomisées pour présenter ici. Mais le ministère, par exemple, pour ma présentation, devrait... il y a même des collègues, des médecins généralistes, quand on présente un chirurgien dentiste, il dit, mais celui-là, ce n'est pas un médecin. Combien de fois moi on m'a dit ça? Plusieurs fois. Et des médecins qui travaillaient au ministère de la Santé. Donc, vous venez d'apprendre que la santé buccale fait partie intégrante. Pourquoi? Parce que les parlera demain, si on a l'occasion, des complications loco-régionales et générales des pathologies dentaires. Et troisièmement, on a vu qu'il y a un lien très important entre les pathologies dentaires et plus de 90%, 90% des pathologies et des pathologies systémiques, les maladies non transmissibles. Et vous avez dit que vous travaillez dans ce domaine-là. Donc, comment peut-on laisser le chirurgien dentiste travailler en solo, seul, dans les cas, la plus grande pathologie que vous avez, quels sont les actes les plus pratiqués? Rien. C'est comme si ça ne les concerne pas. Alors que c'est très lié aux maladies, aux pathologies dont vous vous occupez tous les jours et qui ont déjà des programmes et qui ont duré des années. Et donc, pour m'en arrêter là, c'est ça. Concernant donc, j'ai fait un plaidoyer pour que OMS et Dentaire soient mis au niveau des CDS. Je vous remercie.
Merci beaucoup. Il faut veiller à ce que tout le monde s'inscrit sur la liste de présence. Oui, c'est ça. Nous avons beaucoup travaillé. Nous avons beaucoup appris. En tant que peut-être modérateur principal aujourd'hui pour cette journée, je remercie tous les présents. On a dépassé légèrement le temps qui était imparti. On devrait terminer à 16h, mais il est 16h45 pour le moment, si ce n'est pas plus. Et je vais inviter la présidente de l'association pour son mot de clôture pour cette journée. Et on se revoit demain à 9h. À 9h, je crois, avec la pause. On commencera par la pause café. Non? Ça oui. Ça oui, on commençait. Non, en fait, il y avait quelqu'un qui commençait à faire ceci.
Bonsoir kandi nashaka mfate kanyo kanya ndabashimire umwanya wanyu, shimire abatwitavye uyu munsi. Umunsi wa mbere nibaza ko wagenze neza, twakuye ibintu byinshi twize, kandi nibaza ko benshi twabaye inspiré. Turashimiye abashitsi bacu, aba ohame izo bimeze, murakoze.